Hello, everyone, and welcome to another edition of Mormon Stories Podcast. I'm your host, John DeLynn. It is August 17th, 2021, and we have a very important episode to bring to you today on Mormon Stories Podcast. We are going to be covering the LDS Church's response to the COVID crisis, and specifically in this episode to the COVID vaccine. We've covered COVID a little bit on Mormon Stories in the past, particularly during the first spike that happened last year. But there is a new spike and some new news, and we are going to be covering it today. So I want to begin by kind of talking about my and our intentions from the very outset. Our goal is to responsibly review the evidence, the science behind COVID and the COVID vaccine. We also want to cover the state of the COVID vaccine situation in Utah and in surrounding states. We are not interested in demeaning, or speaking down to anyone who has a various position. We want, if we're going to bring up anyone's counter position to something like the vaccine, we want to steelman their arguments and do the best faith interpretations of what they feel are very legitimate concerns about the vaccine or the COVID vaccine specifically. We want to help as many Mormons, post-Mormons, Utahns, Idahoans, Arizonans, Californians, and anyone else avoid death or unnecessary death or serious injury. And we are not here to be political. My goal is that no political party or candidate or politician ever gets mentioned in this entire episode. I was going to mention that to the panelists before we start. Let's just never bring politics up at all, if that's okay. We're not here to demean any side or position. And we're actually not even here to fearmonger, because fear-mongering doesn't work. I want to give a little bit of background on why I decided to cover the episode this week, and I'll do that just by discussing the news. So I noticed in the Salt Lake Tribune an article just a few days ago that basically says Utah's intensive care units are past capacity as COVID patients surge in numbers. It basically said that the intensive care units are 102% full. This was as of 4 or 5 days ago, that the medical units are 98% full, and that caregivers are stretched thin. To me, that is boots on the ground. That is what's going on right now here in Utah, which is where I live and where many of us live and where the majority of Mormons live. To go on, the Salt Lake Tribune reported, this is Scott Pierce, August 13th, 2021, quote, "I haven't seen morale this low in a hospital I don't think I've ever seen it this low, period," said Dr. Eddie Stenegem, an infectious disease physician at Intermountain Healthcare in Murray. "Our caregivers are really strained. We're in a pretty dire strait right now. Basically, and the medical surgical floors are at 98% capacity, are close behind the ICUs." He's saying, so we're full, completely full. This is not a place that we want to be. And that's the hospital saying that. And that means the hospitals have to figure something out when a trauma patient or someone who suffered a heart attack or a stroke comes in and needs an ICU bed. So ICU beds are full, and people needing care soon are going to have to be turned away or life flighted somewhere. But even the more kind of important or startling news, it says 90% of the COVID-19 patients currently hospitalized were not vaccinated. Quote, "and they could have been vaccinated, and if they were vaccinated, the vast majority of these hospitalizations would have been avoided." He goes on to say the majority of vaccinated patients admitted with COVID, quote, "are people that we'd expect didn't generate a significant immune response to the vaccine." Anyway, he said that he's, quote, "just kind of numb to it all at this point. We've been in this fight now for over 18 months, and we all kind of thought that we'd we've got this effective vaccine that's safe. And I think I had it in my mind that everybody's going to get it that can get it, and we won't be in this situation. So a little more reporting before we bring on our experts. Again, in the Salt Lake Tribune, it reported in the past 4 weeks, unvaccinated Utahns were 7.6 times more likely to die of COVID-19 than vaccinated people. According to an analysis from the Utah Department of Health, the unvaccinated were also 6.7 times more likely to be hospitalized and 4.9 or 5 times more likely to test positive from the coronavirus. So massive increase in likelihood of death, ICU admission, hospitalization, and contracting coronavirus for the unvaccinated. Goes on to say, based on data from the past 6+ months, unvaccinated Utahns are 10.8 times more likely to die of COVID-19, 6.1 times more likely to be hospitalized, and 5.8 times more likely to test positive, according to the Utah Department of Health. And then just because we don't want, many people don't trust statistics these days, which is totally something that I think I can wrap my brain around, or they even don't respect authorities. And so we don't want to just rely on math and statistics and authorities, but also anecdotal evidence can sometimes be useful. And I'll just tell you anecdotally, my mother called me in tears just a couple days ago, and she told me that her dear friend who lives in Draper, who was her neighbor for multiple decades, probably in her 70s or 80s, sang for the Mormon Tabernacle Choir. She died of COVID. She did not get just in the past couple of days. She did not get vaccinated. And it was her children that persuaded her not to get vaccinated, and she just died. My mom was heartbroken about that. I just noticed a post from my dear friend Woody Woodward. This is a dear friend of mine, someone that I know very well. This is a picture of him in the hospital. Here's what he writes on Facebook. Just a day ago, you can go to his Facebook page and see it. He wrote, "COVID kicked my butt, took 21 days to recover. I was not vaccinated. I ended up in the ER twice, got pneumonia on the top of my asthma. If you want to know what it feels like, here's the only journal entry I made." And he talks about being in pain, his bones throbbing. He feels like each vertebrae has a woodpecker going down it. He hasn't been able to sleep for more than 4 hours straight. He goes on and on and on about talking about how awful it was for him. Another listener, Roger Tater, writes, "I have 2 families that are close to friends that are currently suffering of COVID-19 that were not vaccinated. One couple is healing and just out of the ICU. The other couple is home and very sick right now." Whitney writes, "My aunt actually died of COVID-19 after vaccines were made available to the public. She was against the vaccine." Another one wrote, "My sister-in-law, Amy Pearson, is willing to share her story about getting COVID after delaying it. She ended up in the ICU and still has issues, plus a hefty medical bill. She was 5 days away from getting the second dose," and on and on and on. Again, the point is not to fearmonger. We are going to be addressing, I know a lot of people are saying, well, what about what people are calling vaccine injury? We are going to be addressing vaccine injury in this episode. But before we kind of conclude this portion, I am just going to add the news that the LDS Church First Presidency has made a formal statement about the vaccine that goes farther than they've been willing to go before. They wrote, "Dear brothers and sisters, we find ourselves fighting a war against the ravages of COVID-19 and its variants." This is Russell and Nelson, Dallin H. Oaks, and Henry B. Eyring. Fighting a war against the ravages of COVID-19 and its variants and unrelenting pandemic. We want to do all we can to limit the spread of these viruses. We know that protection from the diseases they can cause can only be achieved by immunizing a very high percentage of the population. To limit exposure to these vaccines, we urge the use of face masks in public meetings whenever social distancing is not possible. To provide personal protection from such severe infections, we urge individuals to be vaccinated. That's the most important part. The LDS Church First Presidency is urging all Mormons and everyone everywhere to be vaccinated. Available vaccines, they are saying, the LDS Church First Presidency is saying available vaccines have proven to be both safe and effective. And then they say, and I have cold symptoms myself, we can win this war if everyone will follow the wise and thoughtful recommendations of medical experts and government leaders. Please know of our sincere love and great concern for all of God's children. Again, that's the LDS Church First Presidency. There is a photo of Mormon prophet and President Russell M. Nelson getting vaccinated. So he is not only saying these words, he himself is showing the example. And, even though I'm definitely not a traditional or Orthodox believing Mormon by any stretch, I was grateful to see at least some early response. This response was happy to some and concerning to others, but basically it's a Facebook person saying, our prophet asked us to do these things, and that is good enough for me because I know he speaks for God. Obviously, there are people who have concerns about anyone following anyone with blind obedience. But in the case of the public health, there are many who are lauding President Nelson for weighing in on this matter, and for if the result is that more Utahns, more Idahoans, Arizonans, more believing Mormons are willing to get vaccinated, they're seeing that as a good thing. So today, I am bringing on three, possibly four guests. Excuse me as I cough. And my four guests are Dr. Jeffrey Gardner, Dr. Stephen Caldwell, and Dr. Dwayne Wiesman. Is that right? Wiesman? I'm sorry, I'm having a hard time pronouncing that. That's all right. Dwayne Wiesman. I'll just tell you why I brought these three gentlemen on. So Jeff Gardner is a friend of mine. I know that he studied math at Harvard and also I think went to BYU. Jeff went on to get his medical degree. He's an ER doc in Nevada, but Jeff just has had a particular passion for following the science and the evidence and the data, and just the experiences of medical professionals around him, within and without Mormonism, within and without Utah and Nevada and other surrounding areas. So Jeff Gardner, thank you so much for being willing to kind of help lead this discussion today. It's great to have you back on Mormon Stories podcast.
Nice to be here. Thanks, John.
Anything else you want to say about my introduction?
No, it's
of you
captures it. I'll correct it a little bit.
I've also brought, I think, Steve, is this the first time you've been on Mormon Stories, Steve?
Yep, first time.
All right, Steve. Steve is a dear friend of mine. He's also the brother for the Mormon Stories geeks out there. Steve Caldwell is the brother of Shannon Caldwell Montez, who did the amazing series on B.H. Roberts and the Secret Mormon Meetings of 1922. He's the one who introduced me to his amazing sister, Shannon. But I brought Stephen on because he is an ER doc here in Utah, so he can speak to boots on the ground here in Utah. Steve, anything you want to say about your background before we jump in?
No, I'm from Utah. I did my training outside of Utah for the most part, so I've lived around the country a little bit, and have been in Utah for the last 16, 17 years. So we've had a close-up view as to how Utah has handled this and how we're doing currently. So,
all right, Steve, it's great to have you on.
Thanks.
And then the final panelist that we'll have immediately, and then I'm going to bring on a pre-recorded video maybe later, Dwayne Wiesman. Dwayne, you're a double doctor, both an MD and a PhD. You're joining us from, I believe, Boston, Massachusetts. I'm not even going to try and do justice to your background and expertise. So, Dwayne, do you mind introducing yourself and letting people know your background and expertise and why you were willing and able to join us?
Sure. I'm Dwayne Wiesman. I'm a physician scientist. I see patients with immune deficiencies and other problems with their immune system. And most of my time is spent in the lab studying immunology, in particular antibody responses to infections and vaccines. And I'm on here because I care about Mormonism. I was born and raised in Utah, and I care about vaccines, and I care about science. And I want to be here to help out where I can.
And So you're an immunologist. You have actually participated. If I remember right, you sent me a bit of some of the research articles you've been involved with. So tell us what types of research you have actually. I think you mentioned you are an associate professor at Harvard. Is that right?
That's correct. I'm an associate professor of medicine at Harvard Medical School. I'm a immunologist at the Brigham and Women's Hospital, and associate member of the Reagan Institute of MGH, MIT, and Harvard.
And tell us what research you've been involved with that might be relevant to this discussion, so that people know the extent to which you kind of might have some exposure to and or familiarity with the body of research that's out there.
Yeah, so I've worked with folks at Moderna, as well as Johnson & Johnson, folks affiliated with Johnson & Johnson. I carrying out studies, my laboratory carries out studies on the immune response to COVID-19, as well as to the immune response to vaccination, both in terms of durability of antibody responses and breadth across the different variants and how effective they might be. And as I mentioned, I'm a physician who specializes in immune deficiency, and a lot of my patients discuss aspects of concerns they have about vaccines and side effects. I'm an allergist as well, and so I see folks with that have side effects of vaccines and various other kinds of things. And in addition to that, I moonlight as a hospitalist at a local community hospital around here, and I've cared for folks with COVID-19 myself.
Excellent. Thank you so much, Dwayne. It's so great to have you. Before we jump in, I am just going to address one comment that has really, really frustrated me. Someone on YouTube, Movie Hipster, writes, "John, stay out of politics." When I announced that I was going to be discussing COVID-19 and the vaccine, I just had so many people write me and say, "John, please don't make Mormon stories political. Please stay out of politics, stay in your lane," so to speak. And I just want to address that just head on. Number one, if you joined us from the very beginning, we are committed. We will never be mentioning the name of any political party during this episode. That's my commitment. We are not mentioning any public office holder or leader. We are not here to represent any political party. We are not, we are seeing this as a public health issue, not as a political issue. And I just am really frustrated with people that want to frame this as a political issue. And I just want to say, from my commitment to my listenership and my commitment on this episode, politics will not be entering into this discussion. Does anybody have a quick, pithy, just sort of statement they want to make about that framing that this is a political issue? Anybody? And Jeff, then I'm just going to hand it over to you. Maybe Jeff, I'll just hand it over to you, and we can kind of go from there. But basically, Jeff's going to talk about. He's going to kind of frame the issue. We've got a couple major concerns that people have voiced, and then we're going to have Steve talk about boots on the ground in Utah, and we're going to have Dwayne fill in some information about what he knows about the evidence in the literature, and we're going to be directly hitting several questions or concerns. We're going to be talking about vaccine injury, claims about vaccine injury, and people saying that many people are being injured by the vaccine, and or the injuries are being underreported. We're going to be talking about whether or not the vaccine has been rushed or not tested enough. We're going to be talking about mRNA and whether this vaccine will, quote, change their DNA, whether the vaccinated are contracting COVID, whether this is just normal cold and flu season stuff. These are kind of the main concerns we're going to be addressing, whether this is heavily influenced by financial motives, and again, just this political issue just keeps coming up. So Jeff, I'm going to turn the time over to you if you want to address that political thing right up front, but let's just give you some time to kind of lay the land for us a little bit.
Oh, okay. Thanks, John. I'll start by saying I feel like I'm completely politically detached from this. Of course, everyone probably thinks that, but it'll probably be more about what you guys see, and we'll do our best. I'm just going to try to share my experience with this and try to leave politics out of as much as possible. I'm really passionate about sharing accurate information on this. Just to correct a little bit, my undergraduate major was in economics. And I only say that because when this came out, February was really February of 2020 was when we started hearing about this virus in China. My initial response was kind of, oh, it's not going to be a big deal here. We'll see. We'll kind of keep an eye on it. But I've been through this before. I'd been through SARS-1. I'd been through, H1N1, a couple other things that have come through in my job as an ER physician. And I've always thought people aren't very good at risk analysis. I mean, the most dangerous thing you do every day is get in your car and drive. And yet people are more concerned about being shot in a public park or, these other things that are such minor risks in comparison. And so I felt like this is another thing that the media wants to sell headlines about. They're fear-mongering. They seem much more interested in things other than accurate information. So February, March, even into March, I still felt that way. We were seeing those videos from Italy, and those were scary. But my thought was, well, that's the Italian system. These are docs that are not trained like we are here. I was kind of resisting at every point, and then it got to New York, where we do have well-trained docs, and it was killing us. So that made me a little more nervous. I still resisted any kind of attempt from the government to shut down anything. I just felt like, if we make symptomatic people stay home, why don't we just do that? Like, let's not overblow this. We're operating out of fear or politics more than we are out of accurate information. I started a Facebook group at that time where, first of all, I wanted to know how to do my job well. So the idea was we were just going to go through research, have other smart people in there to bounce things off of and see what they thought. The rule number one was keep politics out of it, because I just wanted to get the accurate information. Anyone was invited. So we had a lot of people from a lot of different backgrounds talking, and it was helpful. It's hard to keep politics out of a pandemic, I got to be honest, because there are sometimes policy implications to some of the evidence that was coming out. But we were trying to keep that kind of bias out of it. I remember talking as things progressed, we got into the summer, we were starting to get full and starting to have some problems. And my thought had always been government action, government shutdowns, those kinds of, and public health rules should keep in mind whether our hospitals are at capacity, because then your choice to take a risk suddenly affects other people. Meaning, if the ICU is full and you have a heart attack, you are going to have problems getting adequate care. So that person's decision to take a risk and get COVID now affects your treatment options when you have a heart attack. And that's where we start to realize we live in a community of people. So I felt like in those situations, government intervention can start to become appropriate. And anyway, July, we had some of these interventions, things slowed down a little bit. I still wasn't seeing like what we had seen in New York, but we were having some difficulties transferring patients, having full ICUs, full hospital beds, treating patients in hallways, things that just aren't ideal. By the way, by way of background, I work in a Las Vegas trauma center. I work in a Las Vegas suburban ER, and then I work in a rural center up in Northern Nevada. So I kind of get a view of a few different situations with respect to this virus. Okay, so progressing on to November, December, things got really, really ugly. I remember thinking back in summer, if we get a vaccine for this, probably just healthcare workers and old people need to get it. I had concerns about it being experimental, untested. The people that were high risk needed to get this. By the time of December, there was a funny meme that came out. I don't know if you saw it, but it totally spoke to me. It was, I was so desperate to get this vaccine. People were saying, I'm not so sure I want this vaccine. By the time December rolled around and it came out, I'll take it in my eye. I just wanted to be vaccinated. I didn't care. It was scary on a personal level. It was scary on a patient treatment level. I didn't want to make other people sick at the ER. And I didn't want to, I saw people like me that were going to the ICU and dying. And I'm a healthy runner. I run regularly. I mountain bike. I'm of a healthy body weight. I try to eat healthy, but no one is the exception here. Kids under 12, maybe they're the ones I can say, I haven't seen a kid under 12 get really sick with this. That's not to say they don't exist, but I've seen every other category of people get really, really sick. And that personal experience, I think, speaks in a way that numbers don't. And I've seen that as people have commented on COVID. I've seen doctors who are pathologists and have never seen a patient, and they feel very free talking about things that they just don't really understand, either on a clinical level or a research level. They just haven't looked at it in the same way. And I think that level of experience really speaks to you. And it's hard to believe numbers, honestly, without having either someone close to you or yourself being directly affected. The doctors in the ER, the doctors in the ICU, the nurses in the ICU and ER, they have a different perspective, and you'll see a different response. I don't know any of my physician colleagues, and I come from a fairly, I know we didn't want to talk politics, but just because it's real in there, I come from a fairly Republican ER group. Without exception, everyone has been vaccinated. And I think like we've managed to keep politics out of this because of the experience we've seen. And I don't know how to communicate that to you without walking you through the ER during these surges. It's really a nightmarish place. This has been the hardest, most challenging year of my professional life. And I lived through SARS-1. I was a resident in SARS-1. I worked through H1N1. We've had some pandemics, but nothing even close to the level of what we've seen in real life, not media communicated life, real life. So that's my background.
So Jeff, what I hear you saying is that you began this COVID sort of awareness with a healthy dose of skepticism, even downplaying it, and what the predominant influence on your positions is just boots on the ground, seeing people die, seeing how full and severe this is for hospitals, for patient care, and just knowing how serious of a health risk this is to yourself and to people around you. Is that what I just heard you say?
Yeah. And I think we're all human. We all think we're very rational, and we try to be, but there's nothing that speaks to you like personal experience. So I empathize with people who haven't felt this hit them. I was there. I know what you're feeling. I mean, as well as I can, but I wish I could communicate to you what we've been through this last year. This vaccine felt like a literal miracle. I got it the day I could. It felt way better than Christmas. I got it December 17th, 18th. And it just felt way better than Christmas. I felt this huge weight. And so it's been a little shocking to me to not see a similar response. I've had to kind of stretch my empathy muscles and go, okay, if I hadn't been in the ER, if I hadn't seen all this, how would I feel about this? And that's healthy for all of us, I think. But yeah, it's a little frustrating too. We are seeing people now fully preventable disease, and that is really hard to still be fully in. I mean, it's our responsibility. I'm not excusing people, but it's hard. It just burns people out. I'm seeing that in the nurses around us. They're leaving the job. They're leaving their jobs. We came in to help people, to heal people, and to have people question both our motives and our expertise. That's a hard thing to face every day, and just so much needless suffering.
Yeah.
Anyway, so my experience, I just want to emphasize it's okay. You know, I was skeptical from the beginning of this. I was an economics major. I knew there were real consequences to shutting down businesses and health consequences to that. And some of that was being ignored up front. But I've really changed my mind on a lot of this. Not everything. There's a few things I'm still holding to, but it's okay to change your mind. In a pandemic, we are learning information every week about how to treat patients, how to diagnose them, what kind of impacts this is having on the society. You should be changing your mind. If you haven't changed your mind on anything, you're not paying very close attention. So I think it's okay to be flexible on this. We need to be.
Excellent. Okay, Jeff, tell us, I mean, one of the things that we put together are a list of questions. Tell us what you want to say in framing. Maybe what we should do, Jeff, is have you complete whatever framing you want, have Steve give his anecdotal experience in Utah, and then we can either jump to the questions or also let Dwayne give a little bit of framing. But what else do you want to say before we jump to the actual, have the other guests on and then jump to the questions?
Okay. I see vaccine injury at the top of that list, and I would agree. That's everyone's biggest concern about COVID vaccine. It's appropriate. We should worry about this. And so I think it's a totally valid objection. What I think it's being misframed in a lot of the discussions, and I'd just kind of like you to step back and look how this virus works. On a couple of, I don't want to review too much, but this is non-controversial basic biology, how viruses work. You've heard about the spike protein. This virus goes into the bloodstream. It attaches to cells using the spike protein. It ejects mRNA into the, ejects its genetic material into the cell. It then co-opts the cellular machinery to produce new virus, releasing into the bloodstream. And that kind of goes, and then those viruses repeat this pattern. So it's an exponential growth of virus and spike protein, right? The virus, or the vaccine, I'm sorry, is a little sliver of mRNA that we inject in. That mRNA is taken up by the cell. And then the cell then produces just this little sliver of protein that's on the virus, the spike protein, right? So the virus includes this spike protein, but it also includes a whole bunch of other stuff that causes allergic reactions, immunogenic responses, causes a lot of other problems. It also has the instructions to reproduce. So what I want to emphasize here is when you get the vaccine, you're getting a slight increase in this spike protein that breaks down over time, but when you're getting the virus, you're getting that spike protein plus a whole lot of other bad stuff, including instructions for that cell for that virus to then reproduce in an exponential fashion. So anything that this spike protein is going to be caused will be caused by the virus and in spades. So just from a physiologic perspective, it's really virtually impossible for the vaccine to cause a problem that the wild virus won't, and in much greater magnitude. That's just from a physiology perspective. So if we step back though and look at what this virus is doing, when I see a lot of people that are saying, well, I'm just going to sit back, wait and see, let's see what these long-term effects are, right? That's a really common objection I'm seeing. Now, if this were Ebola and it's isolated in Africa and there was a way to avoid it, that's a valid question. Like, I can sit back and see how this vaccine does, and I can also avoid Ebola, right? When you make a choice to wait and see on the vaccine, you are making an active choice to get the virus. The virus is everywhere. You're not going to avoid it unless you're going to stay in a hole away from people. So you're making a choice. There's no choice C. You're choosing either the vaccine or you're choosing to be infected. So that's the comparison we need to make. So no, we don't know the long-term effects of the vaccine. You're absolutely right. We know nothing about the long-term effects of COVID. Well, what we do know, it's bad. People who have gotten chickenpox wildly, they face shingles 20 years later. We don't know what COVID could do 20 years from now if you get wild COVID infection. We have no idea. We do know people are getting permanent myocarditis kind of symptoms. We know people are getting permanent lung injury. We know a lot that's going on permanently from wild COVID infection. We are not seeing that with the vaccine. We might in 20 years, it's true, but we're watching really closely right now, and we're not seeing anything even close to the level of what we're seeing with the virus. So I feel really passionate about that. Make the right comparison. You're comparing vaccine versus virus. You're making the choice of one of those two things. If we just look at the death rate, which is really pretty simple to observe, we think the death rate of the COVID virus, by really generous estimates, let's put that at 0.3%, maybe 0.1%, even if you wanted to put it there.
And that means people that are dying who contract the virus?
Yeah, who contract the virus in any way. So this includes all those people that got the virus and maybe had a little sniffle, right? It includes the full denominator of people. This includes you, right? If you're walking around society, you pick up COVID, you have a 0.1% chance of dying. That's being really generous, okay? So we've vaccinated approximately 200 million people in the US. And check my math on this. If we go 1% or 0.1% of 200 million is 200,000. Have we seen 200,000 deaths from the vaccine? No way. I don't care what you think about VAERS or the reporting system or whatever. Nothing puts it at that high.
So Jeff, this is probably one of the number one responses that we've been receiving. And we already have gotten some comments from listeners on YouTube. Jeff, I'm going to ask you to tilt your computer screen just a tiny bit so there's a little bit less room between your head and the top of the screen. Tell us, what is this? So there are people saying that there's this database with reported injuries from the vaccine, and everybody is saying, John, it's wrong for you to bring on people talking about close loved ones who have died from not getting the vaccination without also talking about all the reported and unreported injuries from the vaccine that's in this database. Dwayne, is this something that you, Jeff or Dwayne, is this something that either one of you guys can kind of explain to our listeners and help tease apart?
I just did a post on VAERS, so it's kind of fresh on my mind. I might hit that, and then Dwayne can probably
so this is
fill
called
it in.
VAERS, right?
VAERS,
What
yeah.
is VAERS?
The Vaccine Adverse Event Reporting System.
Okay.
A couple of ways. First of all, I applaud this effort because it really is an extra step towards transparency. Let me just discuss what VAERS is and what those reports mean. First of all, anyone can submit anything to VAERS. If you had a grandma who died 3 months after the vaccine and you felt the vaccine was responsible, that counts as a reported death on VAERS. It can be any kind of distance of time between the vaccine and the injury. It can be any kind of symptom that comes up, whether it's physiologically plausible or not. So while it's an important kind of first step in looking for vaccine injuries, and we've used this in the past for other vaccines, and we have identified problems, it's not at all complete. That information is really problematic. It's very hard, even for a doctor, to establish causation. When you see something happen to a patient, you look for causes and you make hypotheses about that. But even if it happened the day of, 2 weeks later, whatever, there are all kinds of other factors that confound things. So it's really hard to establish that. So to depend on non-professionals making that causation is obviously a little problematic, but it's still valid to listen to the data point. And so, I think for the rotavirus vaccine that came out, this was 20 years ago, we were seeing an abnormal level of intussusception. Now, intussusception is not a symptom a lot of people are familiar with. So if you see a spike in intussusception among people who have had the vaccine, that speaks to a couple of things. It says, okay, these are probably medical professionals making this diagnosis, and this is a different level of concern than if you pass out, for instance, after getting a shot, which happens all the time, even if you get saline in that shot. So we're paying attention, and sometimes that'll raise flags. And then the study is done later, comparing people who received the vaccine and people who didn't. Ideally, receive placebo, so you're really getting a good comparison. But even if we saw an increased incidence in something among people who saw the vaccine versus a population who didn't, that's going to draw some attention. So the first thing to notice is that that anyone can report these. They can do it fraudulently if they want. I don't know if they want to. That seems unusual, but if they wanted to. But also, you're relying on whoever to make that link of causation, which is really a difficult link to make. Now, there's going to be over-reporting and under-reporting. Some people put that under-reporting at 1 in 100. That number is really out of nowhere. There's no justification for that number, I think.
Yeah, that's what I hear a lot, is that only, is it VAERS? That the VAERS reporting is dramatically underreported.
In fairness, it probably is underreported. We have no idea what that number is. There was a Harvard study done that talked about drug. It's not even in the same world. And those numbers have been extrapolated over to this, which is totally not appropriate. But we don't know what that number is. So if we see a spike in a certain adverse event, we can look at both the original studies. Those studies have been really, really scrutinized as far as adverse effects. And then we can look at the continuing data that's being fed. Maybe Dwayne, you can take it from there and see what kind of, is there anything you'd add to that?
Dwayne, how would you answer the question from our listening audience and viewing audience about concerns around vaccine injury as reported through the VAERS database?
I guess it's more specifically, or I feel like that's what I'm doing there, is saying, well, we don't know what level of incidence there is. Anyone can enter those in. We just don't have any control group to compare it to with VAERS alone. There are ongoing observations. People heard about the DVT adverse events that were occurring back in January. So we took a population who had been vaccinated and compared it to a population who had not, and found that the incidence of DVT is no higher in the vaccinated group than the unvaccinated group. And so those are the kind of follow-up studies that really need to be done. VAERS is not the endpoint. It's a very, very early start.
And so, Dwayne, yeah, if you had to do a second take following up on Jeff's to simply explain to our listeners their concerns about, I mean, really what it comes down to is risk of getting COVID and the severity of COVID, risk of getting the vaccine and how that might hurt you, versus just not getting the vaccine and seeing what happens. How do you compare the risks of getting the vaccine with the risks of not getting the vaccine? How would you, and again, trying to explain to our listening and viewing audience that really don't probably understand science or medicine super well?
Yeah, so I agree with what Jeff said. I think it's helpful to for folks to realize that something that really drives the medical community is this philosophy, this idea of do no harm. So, anytime there's an intervention that a medical professional is going to recommend, or some kind of a board that is responsible for approving some sort of a medical therapy or intervention, it is a major responsibility and a major consideration to make sure that the risk benefit ratio is favorable for the benefit. And so this adverse event reporting system is a way to express our collective anxiety about doing something that might harm somebody. And so what this is casting as big a net as we possibly can. So as what Jeff was saying, let's make it so it's open to the public, where anybody can enter anything they want. If there's any possibility that this intervention could have caused some adverse event, please put it down here. Not only that, but let's make it available for anyone who wants to see it. So this is available to anyone. You can see it, you can read it, you can see what people are putting in. And as you can imagine, as Jeff was saying, all of these things that are going in happen without the vaccine. But if there's any idea that it might be associated, even though if the vaccine didn't cause it, we can't determine that at this point. So we want to capture that, cast the biggest net possible, and say, what is the worst case scenario? And as you mentioned, maybe it's impossible to capture everything, but we're doing the best we can. So we capture all of this. We know that there's over-reporting, under-reporting, but we're doing the best we can. We capture this and we make it's available. I say I'm just talking about the scientific community at large, but like the NIH, the CDC, they make it available to everybody. And so I think it helps to just put that into perspective. This is guilty before proven innocent process. Okay. So this is just in case, let's find out what it is just to make sure, because we really do not want to cause harm. Okay. So then we can evaluate what is the worst case possible scenario, what's being reported in the field, what are people seeing? And, we are very anxious to figure out whether or not the vaccine is causing harm. And if there's that possibility, then that information is collected. And there are, instances where, there's some inflammatory thing that comes up, or there's some, and this happens with all vaccines. There is the flu vaccine. There is some very low incidence of adverse events. And, many people get the flu vaccine. We still do it because the benefit outweighs the risk. The benefit outweighs the possible harm. And so at this early stage of this COVID pandemic, that's the process that we're in. But collectively, if you take all of the possible adverse events and we look at it in the worst case scenario, the benefits of the vaccine in terms of its efficacy far outweighs the worst case scenario risks. Far outweighs. The this virus, which is called SARS-CoV-2, it causes the disease COVID-19. It kills people at an alarmingly high rate, and people are dying from it, and this death is preventable. So an analogy is, if someone is drowning and you have a life vest and you're holding it on the side of the boat and the person is drowning a few feet out there where you can throw the life vest to them, you want to make sure that the life vest isn't going to harm them while they're drowning. So you have a decision to make. And so, it is also a responsibility, if there is a potential of safe and effective vaccine, not to at least make that available for at least emergency use in the setting of an ongoing pandemic, which is shutting down economies, shutting down countries, and killing people. This adverse event reporting system is following other studies that were done to achieve the emergency use authorization in the first place. These are studies that are published in well-respected medical journals where, the Pfizer vaccine, Moderna, J&J, others, where they reported their results, where they gave the vaccine or they gave a placebo shot in the arm of somebody that was, not the vaccine, but they gave a shot. So they didn't know if they were getting the vaccine or not. And then they followed these people over time, thousands of people, and they monitored adverse events. And they found that adverse events were similar in those people that were getting just a dummy shot versus the shot of the COVID-19 vaccine. And they showed with the mRNA vaccines that was surprisingly highly effective. They were hoping for at least 50%, and it was above 90% effective for both of these mRNA vaccines. J&J a little less, but still very effective. And so the emergency use followed on that, and then this adverse event reporting system follows on when the use is in the setting of a pandemic, holding the life vest, releasing it so that people's lives can be saved, because that's the indication. This adverse reporting system is to follow on to make sure, as it goes into hundreds of millions of people, let's capture everything we can possibly capture so we can have a full understanding. And we've been doing that. They've been doing that. We've been observing that. And it's the data, when objectively analyzed, reinforce the initial indications that this is a safe and effective vaccine. And this is the timing when the First Presidency message came out. It's after a lot of the extra data from following after emergency use authorization, gathering that data to really confirm this is safe and effective.
Okay, so what I've heard you guys say so far, and now I want to bring Stephen in, because sometimes, as far as I'm concerned, you look at professionals, you look at science, you look at research, you look at evidence, and then if you have any reason to doubt that, you look at what's going on physically in the physical world around you to kind of validate and verify what the research is saying. But what I'm hearing you guys say about the VAERS database is it's self-report, it's not vetted. But even if you take the worst case scenario of comparing all we know about vaccine injury compared with what we know about the real and credible evidence about injury and harm and death from the COVID virus, Jeff and Dwayne, what I'm hearing you both say is overwhelmingly the evidence shows that the risks of not getting the vaccine swamp and dramatically outweigh our best understanding of what we know about the harm and the risks of vaccine injury. Can you guys just give me a quick validation whether I have that right? And Jeff, I muted you just because I was hearing an echo. So unmute yourself before you talk.
Okay. Is that better?
Yeah.
Okay. Of course, I'm not going to answer that with one word. Sorry.
Okay.
I'm just noticing a couple of the comments on this. And I'm not purposely ignoring those. It's very hard to talk and watch those at the same time. So, but in response to that point right there, I feel like it's yes. The one word answer is yes, but people are going to talk about, yes, my relative did fine with COVID, or my other relative got the vaccine and then 3 days later was deathly ill. They're all going to have these very powerful personal experiences that are screaming in their ears. I want to emphasize the reason why we have databases, the reason for science in general, is because your personal experience is limited. Meaning you see the world a certain way. And if we were fine with just operating by everyone's personal experience, we would not need science. I can't emphasize that enough. The whole purpose of science is to take a larger data set from a lot of different people and try to make rules from about how the world behaves. And in particular, how the COVID vaccine behaves, how the COVID virus behaves. So your personal experience, although it's screaming in your ears, it's kind of your duty to shut that out and say, okay, I know I've had this thing happen in my life. Let's see what's happening on a larger scale, because it might not coincide. And the fact that it doesn't coincide is really important. That's why we have to take data and look at it responsibly.
Yeah, that makes total sense. But what I'm hearing you say is, Jeff and Dwayne, your understanding of the evidence of comparing the risks of not getting the vaccine and getting COVID versus the risks of getting the vaccine. I just want your professional opinions. Both of you are saying that that your understanding of the data, of the limits of the believability of the VAERS data compared with the overwhelming evidence that we have of what COVID is doing, both of you would say that your understanding of the evidence is that it's overwhelmingly a safer decision to go with the vaccine than to avoid the vaccine, even with the VAERS reports. Jeff, what's your understanding?
It's not even close. It's not even in the same ballpark.
Not even close. Dwayne, just a final confirmation on that?
Yeah, absolutely.
And I just want, Dwayne, I loved your analogy. If we were to, let's say it's the Titanic and there's tens of thousands of people that are swimming in the ocean about to die, if we were to throw a life preserver at each of those people, yeah, 1 out of 1,000 people may get injured by, the life preserver hits them in the head or it misses them and they drown anyway. Like, any intervention is going to have some impact in some way. The question is, do we not throw the life preservers because in this metaphorical example, 1 out of 10,000 or 1 out of 100,000 people might be injured moderately or even severely? Does that mean we stop throwing the life preserver for the other 99,999? And what I'm hearing you guys say is way better odds of still getting the vaccine than the small minor chance of injury from the vaccine. Right, Dwayne? Was that the metaphor you were giving us?
Yeah, and maybe the metaphor isn't perfect, but just I want to try to add to the metaphor in case there's an additional thing other than the life preserver analogy. It's if you throw enough life preservers out, the water eventually drains and everyone is able to stand on dry ground. And it's not just throwing the life preserver to save that one individual. There's a feature here. We are human. We're humans, and so we're a species of animal here on this planet. And there's another biological entity that shows up every once in a while that is parasitic. So it basically needs humans or other animals as sort of food. So, it uses our materials, it provides instructions. It's a foreign entity that enters our bodies with instructions to make its own self. And by doing that, it could cause, either nothing or it could kill us. And so this fundamentally is a biological battle between one species and another parasite that invades that species. And as a species, we have done remarkable things when we work together. Groups that have worked together are able to go to the moon and go to Mars and put something on Mars and have helicopters fly around. And, no individual can do that. That requires a group of individuals. In the setting of a pandemic where there's a virus that can kill people and I'm seeing in the comments, people saying that, well, maybe I know I'm healthy and I recovered, I'm fine. I know people that are healthy and recovered. That's great. But there are other susceptible individuals that have a much higher chance of dying than perhaps, you might realize. So folks that are older, above the age of 65, have a frighteningly high chance of dying to this virus that they can catch. And the more people that are vaccinated, the less chance that these people, that other people, your friends, family, your parents, grandparents, the probability landscape changes for them in a favorable way, the more that are vaccinated. And so I have friends and family in Utah, and I care about them. And it's just if you do the math, they're more likely to live if more people are vaccinated. I'm very interested in the barriers to, the concerns. What is driving the vaccine hesitancy? What are the barriers that people have to not get vaccinated? I want to understand that. And I've been able to have conversations with my own patients about this. They've brought up concerns that they've learned on the internet and things and we've had fruitful conversations. They've showed me information that they're looking at, and we look at it together, and we try to be as objective as possible. And as a scientist, I'm obligated to keep an open mind. And the process of science is to be open to my ideas being falsified by evidence. And, we want to maximize objectivity. And I think, the scientific institutions are relatively good at doing that. So anyway, I'm rambling, but
this is great, Dwayne. I really appreciate it. All right. What I want to thank you, Dwayne. Thank you, Jeff. What I want to do is now bring Stephen in, because you're right, Jeff. We can't, science is not perfect. It has made mistakes. It will always make mistakes but it's a process. Science is a method of discerning truth. And all we know about science is not that it's perfect, it's that it's way better than relying on anecdotes or guesses or superstition. And so I love what you guys are saying. Science needs to trump anecdotal evidence, but we also, it's a good practice to pay attention to what's going on all around you. And so, Stephen, I want to bring you in really quick. You are an ER doc in, I think, Davis County, in the either Layton or Ogden area. And I just want you to tell us, what are you seeing in Utah as someone who has their boots on the ground and is having lots of personal experience here?
Thanks, John. Well, where do you start? It's been, like Jeff said a little bit ago, it's been an extremely challenging year to practice medicine. When we first heard about this 18 months ago, almost now, we didn't know how big it would be, because we'd had experience with other potential pandemics, and you didn't know if this was really going to reach our shores and if it was going to be as big of a deal here. But this felt a little different to me. As I read reports coming out of China and then Italy, we kind of felt, somebody else phrased it as the hum of menace. Like, you felt something was coming. And I felt like this was going to be the challenge of our professional career, that how we dealt with this pandemic in our communities was going to define much of our career. So we started having meetings as a hospital and as a hospital system and as a group of physicians really early, before we had seen any cases, just as we were watching things unfold in other areas. We started having meetings about how we were going to handle this, what we were going to do when we were overwhelmed, what our triage process was going to be, when our resources were limited, how we were going to determine the utilization of those resources. But as you guys know, it was kind of a slow moving wave, and and we were just kind of waiting and worrying and trying to plan our best and get ready for this. Last April, I had the opportunity to go to New York with the group that IHC sent to help out some of the overwhelmed hospitals in New York. And for me, it was very eye-opening. That was the first time I took care of COVID patients. That's the first time I was exposed to the force of the pandemic. And it was eye-opening. It was eerie to, first of all, travel there. Airports were empty. The streets of New York were empty. You just didn't see anybody outside anywhere. And you realized that this was a real deal. You know, we pulled up in front of they assigned us to different hospitals throughout the New York Presbyterian hospital system. And I worked primarily in a hospital in Bronxville called Lawrence Hospital, New York Presbyterian Lawrence Hospital in Bronxville, New York. And my first exposure was seeing the refrigerated semi-trailers parked out front that they were using as temporary morgues. And I know that there was a lot of people that questioned that thought, well, is this, being blown out of proportion? But when you actually see it, when you see how it's affecting everybody's life in New York, you realize that something big was coming to affect us as well. And I learned a lot in New York, and as both Jeff and Dwayne mentioned, the science has been evolving. Like, nobody knew what was coming. Nobody was fully aware of how this would affect us. And we have been trying to learn as quickly as we can through our personal experience, as well as the collective experience of all of our colleagues around the country and around the world. And so New York was very valuable for us because we could go out, we could experience these COVID patients, experience what it meant to take care of patients with this illness, and then bring some of that knowledge home to Utah and prepare our staffs and to prepare our hospitals and our hospital system for what was to come. And at that time of my career, I'd been practicing for 16 years. And the first COVID patient that I saw in New York was something that I had never seen before. It was a disease process that I had never seen before. It was an elderly gentleman that had waited as long as he could at home because he had heard about how overwhelmed the hospitals were. So he waited about 5 days at home before he came in, and he had oxygen levels in the 40s, which typically are not compatible with life and with consciousness. But was just desperate. Just the utter desperation that this gentleman had to get some relief from this illness that he had been dealing with over the last 5 days at home was palpable. And we tried all the non-invasive measures. We put him on oxygen. We did all these things for him. And the best we could get his oxygen levels were up into the 60s with BiPAP and with 100% high flow oxygen. We could get his oxygen levels up into the 60s. And it became apparent early that we were going to have to intubate the patient and put him on a ventilator. And we brought that option up to him. And at the time, the data for intubation of COVID patients, especially elderly COVID patients, the mortality rate was really high, but it was the only option. And he was so desperate for relief that he was like, do anything, please put me on a ventilator. Give me some relief. And so that was really eye-opening. His oxygen levels dropped as he was being intubated down to 16%. And that's something that I had never, ever experienced in 16 years of practicing emergency medicine. I'd never seen this type of disease process. And so I knew that this was something that was going to severely impact the way that we practice medicine, and that we needed to be aware of new treatment options, that we needed to be able to learn as quickly as we could how to treat and manage this illness. So we spent about 3 weeks in New York and learned a lot from the people of New York. I think that the thing that gave me the most hope in coming home from that experience was just to see how the community in New York rallied behind healthcare providers, rallied behind frontline workers, rallied behind the paramedics and the ambulance staff that were risking exposure day in and day out. It was really humbling to see the outpouring of support, and just to see the community come together. That gave me great hope that this is something that we could get through. Because honestly, like, who does community better than Mormons? That was my experience. I thought that this is something that we were going to be able to come together and to tackle and to get through together. So I was very hopeful. I felt like we were learning new things all the time, that if we come together as a community and follow some of these evidence-based practices, that we would be able to weather the storm and to get through it. It's coming home that it still didn't really hit us here in Utah until later in the summer and last fall, when we started really seeing cases rise. And we started seeing the emergency department fill up and the ICU fill up, and getting to the point at times where we were kind of feeling like we were running out of resources. At IHC, my personal experience, I worked for IHC, and I thought that they did a fantastic job of sacrificing profit in order to have the resources available for those patients that were coming in acutely ill. They were putting off elective surgeries. And for anybody that knows anything about healthcare, that's where most of the money is made, is in these surgical cases, not in taking care of sick respiratory patients. But they were putting off all those surgeries and doing whatever they could to have the resources available, so the system could still function. So once we started hearing that there was an effective vaccine, I can't tell you how excited we were, because people were really burned out. I experienced that in New York. People were burned out. And then as we went through the fall here in Utah, we felt the same. We just felt like we were at our limits, and people were desperate for a solution, for relief from just the waves of sick patients. So we were really hopeful that would make a big difference. And to echo what these guys have said, I've taken care of hundreds of COVID patients and intubated dozens of COVID patients, and unfortunately seen many COVID patients die over the last year and a half. And I don't think that I've seen any significant vaccine-related injury. We have one colleague that had serum sickness, that she became ill for about a week after her first dose of the vaccine. And I've taken care of several people that have come in with symptoms that they were concerned about after being vaccinated, but not a single one has required hospitalization. I haven't seen any anaphylaxis. I haven't seen any long-term injury or illness from people that have been vaccinated. So my anecdotal experience, for what it's worth, has been very hopeful that the vaccine can be the game changer for us. It has been kind of disappointing to see the response to the vaccine. Like I mentioned, after my experience in New York, I was hopeful that we would have that same kind of community togetherness in Utah, and that we would rally behind effective treatments, both masking, social distancing, and then, the vaccine. I'm a father of 6 kids, and I'm as desperate as anybody for things to get back to normal, and for my kids to have normal experiences at school and with athletics, and for us to be able to travel and to do some of the things that we love doing. So desperate to get an effective treatment, but it's been somewhat heartbreaking to see the reluctance and the vaccine hesitancy. And to know that there's an effective treatment. I got the vaccine as quickly as I could. Unfortunately, my whole family ended up getting COVID the week that I was eligible to get the vaccine, and that delayed me for a few weeks. But once we recovered from that, we've all gotten vaccinated, haven't had any significant effects. And, you know, to see this current kind of spike in cases now over the last couple of months, the Delta variant has come through. And at the beginning of summer, I felt like we were kind of maybe seeing, you know, things calming down, that the light was at the end of the tunnel, more people were getting vaccinated. And then it seemed like the vaccination rate slowed down. The Delta variant has come through. And over the last month or 6 weeks, we've seen a huge spike to the point where our emergency department's full. We're seeing record numbers of patients in the emergency department. The hospital is full, not just the ICU, but medical wards as well, and step-down units. So it's a real challenge to have a full waiting room, a full emergency department, have critically ill patients, not just COVID patients, but trauma patients, heart attacks and strokes, and not have an ICU bed to send them to, because COVID patients are occupying those ICU beds. And those COVID patients, unfortunately, oftentimes, once they're intubated in the ICU, they're there for a long time. And it's not a quick disease process. And so when you have a third of your ICU full of COVID patients that are there for weeks, that trickle down effect to the medical unit, to the ER, to the waiting rooms is real. And it can affect everything that we see and do in emergency medicine. So it's been a discouraging process over the last few months to see the disinformation with the COVID vaccine and the hesitancy for people to get the vaccine. In my career, I haven't seen anything more effective or more hopeful. And I think you can make the case in medicine in general that there is no greater success that we've experienced as a medical profession than vaccines, not just this one, but vaccines in general. And this is certainly, you know, to be included in those successes. So.
I love it. Okay. So I'm going to ask you, Steve, and then each Jeff and Dwayne to just reiterate just super short, a few word answers to just a couple quick questions. So Steve, again, you know, how full are ICU units in Utah based on your feet on the ground experience? Just give a quick answer there. How full are the units?
They're totally full. We don't have any ICU. One point really quick, John, is that one of the challenges that we have is actually staffing these hospital beds, ICU beds, medical floor beds. We've mentioned that this has been a true challenge for everybody in healthcare. And we've actually seen a lot of our ancillary staff, a lot of nurses realize that they don't want to be exposed to this anymore, that the workload, that the frustrations, that the difficulty of talking to patients and trying to convince them that this, you know, is something for their benefit, I think has weighed heavily on a lot of hospital staff. And so we've seen a lot of nurses and ancillary staff leave the hospital system. And this is not just Utah. This is nationwide. So I think that's part of the problem, is that we feel understaffed and our beds are completely full. We don't have any space in our ICU. And our intensivists have to sometimes be very creative and put patients in other areas of the hospital to try to manage them. Okay.
So Steve, what I'm hearing you say is ICU beds and rooms are full, correct?
Correct.
Jeffrey, how about unmute yourself when you talk? How about in Nevada? What are you seeing, Jeff, in Nevada? ICU beds, emergency, you know, how full are hospitals there in Nevada?
Yeah, it's the same situation. I'm in Vegas. So, you know, our main centers are Clark County down in Vegas. And there's also a center up in kind of the central area of care up at Reno and Washoe County. So I can't speak to Reno. They were full. I can't speak to their situation, but yeah, we're full.
All right, Dwayne, this is just kind of a rapid firing round. I just want to lay down a few basic things. Dwayne, go ahead and unmute yourself. how full are things in the Northeast? How full are ICU beds, ER rooms, etc.?
I only have experience with the community hospital I work in. I haven't been in the Brigham ICU, so I can't speak to that. It's not as bad in Boston. The vaccine rates, though, are much higher here.
Okay, so when the vaccine rates are higher in, let's just say, parts of the Northeast than in parts of the West, like Nevada and Utah, what you're saying, Dwayne, is the situation in the ICUs is less severe. That's what I'm hearing you say.
Yeah, hospitals are full for many other reasons, but the ICU beds and with COVID, I'm not hearing that it's overfull right now.
Okay, so Dwayne, I'll ask you to represent other parts of the U.S. or just your understanding of the science overall when I ask these rapid fire questions. So next question, starting with Stephen, for the ICU beds that are filling up, the overwhelming majority of patients, tell us what your understanding is about them related to the vaccine and what they're in the ICU for. Stephen, just
so
reiterate.
The most recent data, only 25 to 30% of the ICU patients are COVID patients, but 99+% of those COVID patients are unvaccinated.
That's what you're seeing in.
Yes.
Yeah.
Only about a third of them are COVID patients, but almost all those that are sick enough to be in the ICU are unvaccinated patients.
Okay. All right. Jeffrey, same question.
So repeat that question again. You're saying how many?
To what extent are COVID patients filling up the ICU rooms? And of those COVID patients that you're seeing, what percentage of them in Nevada or where you are vaccinated versus unvaccinated? I just want to make that really clear.
Okay. I can speak anecdotally. I haven't seen the overall numbers outside of the studies everyone's seen, but not Nevada specific. I have admitted zero vaccinated COVID patients to the ICU. None. I have admitted maybe one. I can think of one out of all the COVID patients to the hospital. One of them was vaccinated, and it was kind of a soft admission. They weren't really sick, but they were old.
And then the ones that are admitted with COVID, overwhelmingly regarding the vaccine.
They're all unvaccinated. Yeah, everyone else is unvaccinated.
Almost all of them, yeah.
Okay. Dwayne, your experience kind of where you are or just kind of with your understanding of the data, same questions.
Yeah, nationally, that is absolutely the case everywhere. So people that are getting severely ill with COVID are overwhelmingly unvaccinated people. Vaccinated people can get COVID, but it's a minor fraction of that. And those that are getting severe, it's 99% that are unvaccinated.
Okay, Stephen, back to you. This is great. Stephen, back to you. For how much have you treated and or seen people go to the ICU for vaccine injury? Just summarize that one concern.
Not a single case.
A vaccine injury.
Not a single case.
Okay.
I have not had to admit anybody to the hospital for a vaccine injury. I have not seen a single case.
Jeff, what's your experience?
Yeah, no, doesn't mean they're not out there, but I haven't seen any.
Okay, you're not seeing any. Dwayne, same question and your understanding of vaccine injury nationwide prevalence.
So there are cases where we cannot rule out a potential vaccine injury given the proximity to vaccine. So I think guilt until proven innocent, there's a very small number of cases. I know of one that I was personally involved in as a consultant from immunology, and the person is fine, but it was a potential vaccine related hospitalization.
But overall, prevalence of vaccine
that's all that I know.
Compared with COVID unvaccinated deaths or illness.
Oh yeah, unvaccinated COVID deaths happen all the time.
Okay.
The vaccine related injury, I know of one that was hospitalized. The person recovered well and is doing fine. And that's, I think, generally nationally as well. It's rare to have a severe event from the vaccine.
Okay. I mean, I don't know how else to, I talked to a UVU professor who really tries to understand vaccine hesitancy and vaccine resistance. And he basically says there's three groups of people. There's a bunch of people that have already got the vaccine. There's some people that are on the fence. And then there's a bunch of people that no matter what you say or do, it's unlikely they're going to be convinced. I just want to make it clear in this program. We're speaking to people that are open-minded, that are willing to consider the evidence. And so far, I don't know how else, other than bringing on experts, talking about our best understanding of the science, and then having 3 different people talk about what they're seeing boots on the ground. I don't know how else to kind of make this point. What I want to do now is go to kind of some of the most common concerns, and I'm going to ask each of you to try and resist, as you're doing so well. Avoid the tendency to get really wonky or to talk too much in details. Just we'll go around the horn, let you respond. So there have been tons of comments. I'm trying to keep as many diverse comments available. If somebody's just blatantly spreading misinformation in the comments, I'm blocking them because I don't believe in spreading misinformation. But I'm trying to keep all sides of commenters who are trying to comment in good faith and specifically ask questions in good faith about some of the valid concerns. So it's time to address some of the other valid concerns. And I just want, brief but really punchy answers to the extent that's possible. So we've addressed the VARS reporting system. Those of you who missed that, go back and listen to that. We've addressed vaccine injury, short and long term. Now we're going to address several other good faith concerns. One is that the vaccine was rushed, that it wasn't tested enough, that it didn't have formal FDA approval. Dwayne, I'm going to ask you to start and address in a pithy, brief way. What would you say to people who say that the vaccine just hasn't been tested enough?
Okay, so I think regarding this, I think this is a valid comment and thing to talk about. So this was done as rapidly as reasonably safe as possible in the face of a pandemic threat with all the harms that we were just discussing. So I think it's what has been done is to match to speed up the approval process in a way to match the severity of the threat. So I think that is the justification for trying to do it quickly. This was not cutting corners with what I described before as sort of the general anxiety that the medical profession feels about making sure that we do no harm, so to minimize the risk, but at the same time to maximize the potential benefit of life-saving interventions. And so another thing to consider is after emergency use authorization, continued work is ongoing, and so far it looks to be that this is a safe and effective intervention.
Okay, so your understanding, Dwayne, is that yes, they had to rush because it was an urgent global pandemic, but that it was still conducted in a safe and effective way. What about, Dwayne? We've already talked about it. There's kind of the trials, and then there's the actual data from people who have now received the vaccine, correct? That's important too. You do the trials, but then you look at the data of the actual administration of the vaccine, correct?
Correct. So the emergency use authorization was not given before a thorough analysis of the clinical trials. These were randomized, placebo-controlled, blinded studies. So the people consented to be a part of a study. They were told you can either get a placebo or an mRNA vaccine. We're not going to tell you which one. They gave you a shot. The physicians also didn't know. Upon unblinding, they found the effects. They were able to look at the adverse events in each arm. They looked at the efficacy of people who are getting COVID. And it was based on that they provided the emergency use. So they didn't cut corners there. The other reason why this was so rapid is because of advances in technology. So prior approvals of vaccines had taken years before this. Advances in technology helped to move this along more quickly as well. So it was a combination of let's try to get this done quickly on the regulatory side as safely possible, together with the advances in technology, the mRNA technology, which has some advantages in terms of being quicker, and together that kind of made it so this was a rapid thing.
And for those who value, some people just don't value science or don't value evidence or don't value authority. And, I understand that people have reasons. I just want to kind of, for those who do respect science or evidence or authority, Dwayne, I just want to reiterate, I think in our conversation prior, you were even recently on a call with the Attorney General of the United States. You're working again with both Harvard University and local hospitals there. So, I mean, you're kind of in touch with some of the thought leaders or the actual scientists and researchers and public health officials nationwide. Is that correct, Dwayne?
Yeah, that's correct. Yeah, I know the guy who started Moderna. I was on a call. I went to residency with Vivek Murthy. I was at a alumni dinner with our alumni. It wasn't a dinner. It was an alumni Zoom call. And just sort of a meet and greet, kind of hear his thoughts on the matter. And, I was impressed by his thoughtful approach. And someone asked him about misinformation. His response to that was that, to sort of validate concerns and to hear people out and to, just to kind of take a data-driven approach to try and figure out how to, work on this together. So I thought he was a thoughtful guy.
Thank you, Dwayne. Jeff, anything you want to add just about the vaccine being rushed or not receiving formal FDA approval that would add substantively to what Dwayne said?
Just the note that not making a decision and waiting for all the evidence to come in is the equivalent of choosing to be infected. So we just don't have the luxury of waiting around for an FDA.
Yeah, or infecting other people, right?
Yeah, that too, right.
Stephen, anything you want to add to that question?
Well, like Dwayne mentioned, I think it's important to remember that this is a technology that's been in development for decades. It's not that they started from scratch, 18 months ago, but that there had been progress with mRNA vaccines going on for quite some time. And fortunately, they were able to accelerate things, but it's not a brand new technology. And I think that the risk benefit ratio kind of certainly accelerated things, but in consideration of the pandemic, I think that things were done very appropriately.
Okay, brilliant. All right, next question from our listening audience. Something about mRNA. There's kind of this rumor that there's someone who is involved in the development of the technology of mRNA, and that this person, I don't even know if I want to mention the name, but that this person has said, don't trust the technology, don't trust the virus. And then there's other theories that maybe the mRNA will change their DNA. Jeff, do you want to, I guess, Dwayne, do you want to start with that? And then we'll go to Jeff.
Sure. So, this is a great question, and I just want to point out that, some of these questions that are coming up now are just as valid as when they came up very early on when people were working on this. And so this has been looked at. Is it possible? It's extremely unlikely. But, I think it's important to realize that viruses have RNA, as coronaviruses, including SARS-CoV-2, which causes COVID-19, has RNA as well. So if you're getting the virus, you're also getting the RNA from the virus, and you're getting a lot more of the RNA from a virus compared to the amount of RNA that they're injecting into your deltoid. And if you're concerned that having RNA kind of injected into your body, the virus injects its RNA into many more cell types than just muscle cells. It goes into your endothelial cells, into your lung, into epithelial cells, and it could, so if that's the concern, we should be, riddled with not only SARS-CoV-2 RNA, but all the other viruses we've ever had, and all their genetic material, DNA, RNA, will be a part of us. And, in a sense, sometimes that does happen, over evolutionary history. You could kind of see that pieces of DNA swap every once in a while between species. That's why we have a placenta. It was a retrovirus that added its, ability to sort of fuse cells together. And that's and that thing, mammalian, biology thanks that event in the past. That kind of event is extremely rare. That kind of process, which integrates nucleic acid into a genome, is specialized. RNA is not really known to do that, and we're kind of bathed in all kinds of genetic material from all kinds of viruses and things all the time, and that and we're okay. So to put a tiny bit of RNA in comparison to what the virus gives us in the deltoid is not that much of a concern if you think about this. If you think about the scientific rationale of what you would worry about, but on top of that, it's the fact that this has been shown to be relatively safe, and with these concerns, which I would call minor in my view, the way that I look at it, compared to the enormous benefits of this vaccine, it sort of favors getting the vaccine.
Okay, so what I think I heard you say is that if you're concerned about your DNA or your RNA being changed, the coronavirus, the COVID virus is going to do that a lot more substantively than a vaccine. That's going to happen even more so. So that's not good, just basic sound logic to avoid the vaccine out of concern for your RNA being changed. Is that what I heard you say, Dwayne?
Yeah, absolutely. The virus has a lot more RNA and it's injected into many more cells.
Okay. Jeffrey, anything you want to add to what Dwayne said about that?
No, I think that was great. The tiny little thing would say the virus's purpose is to reproduce. It would like nothing more than to integrate into your DNA if it could. The vaccine's purpose is not that. So yeah, just like he's saying, the risk from COVID infection, and indeed the whole reason they're even worried about this possibility is they saw a few COVID patients that were still expressing viral antigen that were not actively infected. So they were concerned that maybe it had integrated into the DNA. But that's the whole reason. It's from infected people, not from vaccinated people. So people who are sharing that as a concern, it's okay, and we're looking into it, but it's just not real at this point.
Something about science is you just have to go with the best information you have.
Exactly.
And then science updates itself continually. Steve, anything you want to add to this part of the conversation?
No, I agree with what's been mentioned.
Okay. Next question. A lot of people, this is one of the most common comments that are being made. And by the way, if listeners who are COVID vaccine hesitant or COVID vaccine averse want to ask questions to 3 medical doctors and 1 immunologist, now is your chance. So I will be asking them credible, sincere, heartfelt questions that you post right now. I'll integrate them. One of the most common comments made by listeners is, well, I know people that got the vaccine and they're still getting COVID. You guys have already addressed this, but I want you to address it again directly and succinctly and powerfully. Jeff, I'll have you go first on this one.
I'm actually going to pass this off to Dwayne because this is his field.
Okay, Dwayne, my loved one got the vaccine and they got COVID anyway. What would you say to them practically?
So we expect that because the vaccine is not 100% effective. Only very few vaccines are 100% effective. So when the data came out that it's 95% effective this was tested against the original variants. The Delta variant, it's slightly less effective. Still effective, slightly less, and we're learning. We're continuing to learn about that now. So yes, people with vaccines will get COVID. If they hadn't gotten the vaccine, we know that the probability of them getting more severe is very high. And we know that people that do not have the vaccine are the folks that are filling the ICU beds now.
So what I'm hearing you say is that, yes, 5 out of 100 people that get the vaccine possibly will get COVID on average, but that's not using good logic, because what you're forgetting is there's at least 95 other people out of the 100 that won't get the COVID because they got the vaccine. Is that what you're saying?
Consider the denominator, basically, the number below.
It's just math. It's just math. But just because some get it, still get COVID after the vaccine, that's not a good reason to not get it. I also want to just address something very significant. This is a really huge concern that we should all have. As I understand it, if we don't reach a certain level of population immunity or herd immunity, what we risk is that the virus keeps swimming around in the population and developing new variants that can then become super deadly or lethal and reinfect all the people that have already received the vaccine. And so that's the big risk we're facing now. If we keep allowing the virus to keep swimming in the population, it is going to eventually, we risk it invalidating the vaccines that everyone has received. Anybody want to speak to that? Is that correct or not correct?
That's absolutely correct. So there are many reasons to get the vaccine. I see people in the comments saying, I'm in the demographic that I'm not going to get sick either way, so why get the vaccine? There are multiple reasons to get the vaccine. If the virus goes through people, it has a chance to mutate, and it continues to do so. There are new variants. There's a Lambda variant in South America that looks to be very transmissible. The Delta variant is much more transmissible compared to the parent strains that it came from, and so it will continue to do so. If everyone were vaccinated, or if we exceeded our capacity, or met our capacity to vaccinate people by having everyone vaccinated, the chance of having a variant is much less likely. And so having folks that are unvaccinated does increase the risk of future variants that might defeat the current vaccines. Yes.
Excellent. Jeff or Stephen, anything you want to add to that?
Oh, Jeff,
Jeff, you're muted. Unmute yourself. Sorry, I mute you guys sometimes.
It's okay. Just to add on to what Dwayne was saying about the fact that it's not 100% effective against Delta, still people who are getting these breakthrough infections are still less likely to pass it on to others. So that, in addition to the fact that we're just incubating more variants by not getting vaccinated, I think the two of those should answer that question. I wanted to add one more thing, because Dwayne talked about this yesterday when we were having a phone conversation. He mentioned the idea of people who had gotten COVID naturally. First of all, comparing their level of immunity versus people who've been vaccinated. And then also, is there any point to someone who's had COVID naturally? Is there any point to them getting vaccinated? Because Dwayne had some good data on this.
Yeah, so that has been a question. I already got COVID. I've got the antibodies. Yeah. So do I even need to get the vaccine once I've had COVID?
There's some great immunologic data that shows what antibody levels do, as well as clinical data in terms of who's getting COVID. And just recently, a study from Kentucky, it's posted on Forbes. They covered it. I think it's on a CDC webpage now. It's basically a twofold risk reduction of getting COVID if you got the vaccine after you recovered from natural infection versus if you just recover from natural infection. So the reinfection rate is higher if you don't get vaccinated after recovering from COVID. And we have studies in our groups. We have a group of people that got COVID, recovered, got the vaccine, and they have the best antibody responses. So yeah, that's kind of the situation. So, I mean, you don't want to get COVID to do that, but.
So what I'm hearing you say is, if you get COVID and don't get the vaccine, you're actually more at risk. But if you get COVID and then get the vaccine, you're actually in the best situation. Is that what I heard you say?
Well, if you get COVID and recover, you have some immunity to getting reinfected. So you're more protected than someone that has never had COVID or has not been vaccinated, but you're not as protected as getting the vaccine.
Okay, got it. I made a misstatement and they're calling me on it. Heather says, so I was listening until they said only 5 vaccinated people out of 100 will get COVID. That's not even the data. So I must have made some misstatement somewhere. Do you guys want to clarify that so I don't undermine the credibility of the panel? Did I make a misstatement where I said?
No, 95. I think that's correct. I think a 95% effectiveness at contracting COVID. That was the original strain, the original like Moderna study. If you get 2 doses of Moderna, I think it was 95% effective. And if I am wrong on that, I'm open to be corrected as well. But I think that does mean that let's see, how does that work? Yeah, I think that is in general correct what you said, John. But I'm happy to be corrected.
I mean, I think that's changed with the Delta variant. I think that was maybe her point that we're down to maybe 70% effective against COVID infections, Delta variant infections.
Heather's saying 95% effective against hospitalization or death, not infection.
I think it was 99%.
Yeah, that's not true, Heather.
So you guys are saying it's 99% effective against hospitalization or death.
That's my understanding.
Okay.
Yeah, but if I'm wrong, I'm happy to read.
Okay.
That. But yeah, that's
Heather. If you've got better data than these guys, just share it with us because we want.
Yeah, I'm happy to look, but okay. In any case, your point is correct. Against the new variants that are predominant now, they're much less effective than 95%. We're still in the 70s. And correct me on those numbers, but it's still around 70% effective against infection at all. And we're still very, very I still think high 90s against hospitalization or death, even with the new variants.
Yeah, that's correct.
So your point is taken.
And David makes the point that a 95% effectiveness is a really good effectiveness rate for a vaccine.
Miraculously effective.
We all got vaccinations as kids with much lower effectiveness rates. Is that true?
Yeah.
Yeah.
Yeah, and most of us get the flu vaccine every year. That's much less effective than that.
For sure. Okay, so what I'm hearing you say is, yes, the vaccinated will still get COVID, but at much lower rates, and once you've been vaccinated, you have a much less risk of hospitalization and or death. So don't avoid the vaccine just because some people who get the vaccine still contract COVID. Okay, this is another one of the major comments that people are making. I almost mentioned a name that I promised I wouldn't mention. So there have been people in the news that have basically been touting various treatments for COVID that are different from the vaccine. And I don't even know if I want to mention the names, but maybe we probably should. What is your guys' understanding about the perception of other treatments besides the vaccine? And if there's any science or evidence that those quote alleged treatments are valid. I was going to say Dwayne maybe could take this first, but Dwayne, it looks like Dwayne stepped off camera for a second.
I actually think this is kind of Steve and I's wheelhouse.
Okay, so Jeff, why don't you go first? You guys, you're trained to treat.
Yeah, this is our specialty.
Okay, so Jeff, what's your take on other treatments?
So hydroxychloroquine was an interesting one. Hydroxychloroquine, we started to look at this in March of 2020, by the way. But the theory is that in a test tube, it works really well against a variety of viruses, influenza included. There are some other viruses, I can't remember the name just offhand, but influenza was the big one. So there was some real hope it was going to work for influenza. It failed every randomized controlled trial it was used in, which is odd. Even things that don't work, you do enough RCTs and they'll show an association just by random variation. So it failed every time it's been tested against influenza. Now, it's worth trying, right? On SARS, we didn't have anything else. It's cheap, it's generic, it's widely available, it's fairly safe. It has a couple of downsides, but sure, it's worth trying. Now, we had some political people that heard about this and thought, yeah, works great. And the rest of us are going, whoa, wait. We've seen 100 drugs like this. We've also seen this drug with similar hopes in other illnesses, and it's failed. So let's just wait and see. So we need the randomized trials, right? There's this observational data that said, people that took hydroxychloroquine did better. Of course, we need the randomized trial. That's why we do this. That's why we do science. You have to compare it against no treatment, or you don't know what the treatment did at all. So hydroxychloroquine, I think, has been very thoroughly debunked at this point. We have lots of RCTs that show it does nothing except maybe add a little harm. It adds some QT prolongation. I see some comments on arrhythmias that there's some real harm that comes from hydroxychloroquine. Thankfully, that's out of the news, so we're not talking about the most
So
of the time.
Jeff, you are motivated to get people better because you are literally a doctor on the front lines. And you're saying you would never ever prescribe.
No.
Say the name again.
Hydroxychloroquine,
You would
HCQ.
never prescribe that to a COVID patient.
We ER doctors, we love generic drugs. They're cheap. Our patients can get them filled. We would love nothing more than to see that work. But we've seen this. We've gone through this rigmarole 14 times with different drugs, and including this one. So we were just waiting and seeing. Didn't work.
All right, Steve. What about in Utah for?
I have another one, but go ahead.
What about in Utah?
So there's like Jeff is saying, there's a lot of things that have been tried, things that created hope initially, that we thought it's worth looking into some of these things. The only effective treatment that we have been able to find is monoclonal antibody treatment. So antibodies against SARS-CoV-2 that have been infused into infected individuals. And there's kind of a narrow therapeutic window for that you have to get those within the first 7 days of being treated, that there's a bunch of factors that would disqualify somebody from getting that. So there is some hope there, but that's not a quick and easy treatment. That requires coming into the hospital to get IV infusions of monoclonal antibodies. But outside of hospital, ICU level treatment, high flow oxygen, there's very little therapeutic interventions that are going to be effective.
I actually had one listener ask me about just vitamin C. There are people that think maybe just vitamins or supplements. Have you guys heard anything about kind of homeopathic remedies? And are there any? And Dwayne, we didn't give you a chance to step in to talk about hydroxychloroquine, monoclonal antibodies, vitamin C, homeopathic remedies. We can ask Jeff and Stephen to keep going on this, but Dwayne, is there anything you're dying to jump in to say about this from just a treatment standpoint?
Jeff and Steve said it all about hydroxychloroquine. I agree fully on that. It would have been great if it worked, because it's something, we want things to be able to treat people with. Someone mentions ivermectin as well. Ivermectin is another one of these things in the category similar to what hydroxychloroquine was like. It's, there's an interesting story that someone put a non-peer-reviewed preprint on a preprint server. And so this is something that people do to kind of get some feedback while their study is being reviewed. And as a part of science, stuff gets reviewed, there are feedback that come in, and someone pointed out some things in that study that showed that ivermectin might be helpful. Folks on the internet pointed out some things that don't add up. And based on those concerns that were looked into by the preprint server itself, that was taken off the preprint server. And so the study, I believe the investigators were from Egypt. They, I think there's a paper in Nature, a highly respected scientific journal called Nature, that talked about the ivermectin. That that there's really at this point no reliable evidence that works. I don't think there's any conspiracy or anything to try and hide any potential drug that might work. I think that might be the perception. If it did work, we would be open arms. But as I mentioned before, as physicians, we want to do no harm. So if we're going to give something to somebody with known side effects like hydroxychloroquine and ivermectin, which we know have side effects, we want to make sure it has some benefit. And at this point, there's no evidence of that.
So Jeff and Stephen, you guys didn't weigh in on ivermectin. That's another one that people are putting forward. Steve and then Jeff.
Yeah, I agree that the data that I've seen for ivermectin, like Dwayne mentioned, there was some preliminary data that made people hopeful, but that has not borne out as it's been looked at more intensively. There's zero data that shows that ivermectin, that the benefit outweighs the potential harm.
Jeff, ivermectin?
I'm going to call myself a little more open to ivermectin. We started looking this now with a lot of skepticism. We started looking this like last May or June. There was a lot of stuff from sub-Saharan Africa and then extended to other people. And we've seen a lot of observational studies. And I can't emphasize enough that if you do not have a randomized control trial, you have nothing. We have observational studies for all kinds of things that have failed. There was the RCT that came out. RCT is short for randomized control trial. That came out, I'm going to say, a couple of months ago. And there have been some questions about data reliability that Dwayne mentioned. That's the only one that has been a randomized control trial. And that makes me extra skeptical just because we've had a long time to do these. And the fact that no one's published one makes me really wonder if there's going to ever be a positive one. But until there's a positive one, it's irresponsible to use it widely. I don't think there's a huge downside to it. It's fairly safe. Let me just hit the other one. So you talked about vitamin C and D, and I think this is kind of our wheelhouse, and I've done lots of research on this. So vitamin D works I think it's good. We have decent evidence, good enough in that it works in a preventive basis. So, and I think during flu season, everyone should be taking vitamin D, like 2,000 IUs of vitamin D. That's we don't know the ideal dose, but there's very little downside to that. And it can work equally well with COVID as far as in a preventive way. It's not 100% effective or even close. It's not even close to the effectiveness of the vaccine, but to add something on that has very little downside. Vitamin D is not a bad idea. These super doses that are being advocated have absolutely failed trials. There's no data supporting that. These are the super doses that you give once someone's sick. There's really no data or physiologic mechanism for it to work once you're sick with COVID. The other thing is the super doses of vitamin C. There's this group of critical care doctors with great credentials, great education, great training, whatever, that are forwarding this treatment regimen, including ivermectin, vitamin D, vitamin C, and melatonin. I think people need to understand the context here. There's actually a quote from one of them that said they don't believe they don't believe in RCTs, which I think is unconscionable for anyone interested in science to say. You still have to be interested. But again, they have no control group. The individual remedies that they're advocating have failed controlled studies. They're talking about superdoses of vitamin C, which again, there's not a real downside. It's a little bit hard to administer. But I want you to remember that there is no controlled trial. And these guys also, that one of the investigators, they also advocated this as a treatment for sepsis a couple of years ago. Got all of us ER doctors really excited about this because we don't have, sepsis is a deadly disease. It's really hard to treat. And vitamin C is cheap, effective, easy. We all got really excited about it. And then the RCTs came out and they all failed. So this person in particular, who is a group of, there's a few of these critical care doctors, they're advocating therapies they know have failed RCTs, which just makes me wonder, why are we trusting you now? They're deliberately being dishonest about this. And that kind of gets me, that bothers me on different levels than just we're trying to find a treatment in a pandemic. There are some deliberate dishonest aspects to that.
Okay. So what I'm hearing so far from everyone is hydroxychloroquine, ivermectin, vitamin C or D, none of those have passed the muster of randomized clinical trials. Monoclonal antibodies have shown some efficaciousness if you get it the right time in the right way, but none of those come even close to the effectiveness of just getting the vaccine. Is that kind of the consensus of the panel?
Right.
Anything else you guys want to say about any other homeopathic remedies that are prevalent or common that you're hearing about?
Well, I think the other one, like Jeff mentioned already, was vitamin D. It makes sense to take vitamin D in addition to doing the other preventative measures that we should be doing, mask wearing in big population centers, washing our hands. So vitamin D makes sense in that regard, but not as a treatment for COVID-19.
So vitamin C or D in place of getting the vaccine?
No.
Okay. A couple other concerns people have voiced. Some want to say this is just normal cold and flu season, that what we're seeing is just what happens every year. Really quick, Stephen, what's your response to that this is just normally what always happens?
No, for several reasons. I mentioned earlier about my first patient in New York, and it was clear that was not like any flu, cold, respiratory virus that I'd ever seen. And that's kind of repeated itself many times since then as I've taken care of more and more COVID patients, that this is clearly a separate illness. People are getting way sicker than with any cold or flu virus that we've ever been exposed to. And when you consider that flu season, for example, people compare this to the flu can be very deadly. and we need to take the flu seriously. But the flu season is generally just during the winter months, and we'll get a 2 or 2.5, maybe a 3-month period of a flu season where it'll run rampant in our community. But we're in August, and our ICU is full right now, and our ERs are full, and our hospital beds are full with COVID patients. We never see that with influenza, and we never see that with any other respiratory viruses. It's clearly different physiologically. It's much different as a population health concern as well.
Okay. Jeff, anything you want to add?
Just because of the comment from Bridger Bateman, he mentioned the Math Plus protocol. That's what I was just talking about with those Florida critical care doctors. It's failed. Every individual aspect of it's failed.
So just to repeat, summarize that for people who have no idea what you're talking about.
Well, so there's just a comment I just happened to see pop up. Says, I'm not sure if I missed it yet, but I'm wondering about the Math Plus protocol and its success or failure. That is melatonin. That stands for, I think, melatonin. I can't remember the exact acronym, but the individual components of that: melatonin, vitamin C, vitamin D, hydroxychloroquine, and ivermectin, I believe. I might have been missing one of those, but every one of those has failed individually. They know this. I would love to see this in an RCT, and if it works, great. I will be the first to adopt it. But given their history, I'm skeptical of this working. They've for a few other reasons too. He also talks about ADE, but I think we can get back to that. And
so I just want to make the point of what's kind of obvious. We have 3 people here on the show that spend their professional careers every day of their lives treating COVID patients. You guys have taken the Hippocratic Oath. You have every desire and every motivation to have your patients get better. And what you're all saying is there is no known superior approach to COVID than getting the vaccine. Nothing that even comes close that you are aware of. And if you were aware of something, you all would be prescribing it immediately. Do you all agree on that?
Absolutely.
Yes.
Yeah.
Okay. Anything else on this is normal cold and flu season sort of argument? Anyone else want to say anything about that? Dwayne, anything you want to say about this is just normal, what happens in ICUs around this time of year sort of thing?
Yeah, it's not. It's more severe. More people are dying. It's closed countries, and so it's different.
And Jeff, you work in an ER full time. Your professional opinion?
We do flu season every year, and we've done bad flu seasons. H1N1, we've done SARS-1, we've done bad stuff. This is far and beyond anything we've ever seen.
Order of magnitude worse.
Yeah,
right?
not even close.
Not even close. Okay. The next sort of category of concerns is financial motivations, and I want to take them each sort of separately. So one is just at the doctor level. It's sort of this logic that doctors make more money if people are sick. So doctors are lining their pockets by making the COVID thing a bigger deal and wanting lots more patients to get more rich. So COVID is like a monetary bonanza to doctors. And then we're going to get to hospitals and to the government and to pharmaceutical companies. So Stephen, are you motivated by all the extra money you're making with COVID patients, you personally?
Last year I got paid much less last year than in previous years. I think COVID has been negative for us from a financial perspective. And there is no financial incentives to diagnosing people with COVID. I know that people were saying that early, that doctors or hospitals got paid more if you included that on a death certificate. I've never been paid for signing a death certificate. You take care of a patient, and that's paperwork that you have to do at the end. But there's been zero financial benefit to me personally, to any of my colleagues working on the front lines in dealing with COVID patients. And it's thrown such a wrench into our system that it's been financially negative for everybody that I know and work with.
Okay, so not lining the pockets for you, Stephen. Somebody just stated, oh my hell, John, that is such a straw man. Listen, Cole, we are doing our best to steel man and address legitimate concerns. I am not I mean, hopefully all we've already addressed, Cole, is showing that we're trying to steel man and not straw man people's arguments. But I am going to list other arguments I hear just as an attempt to be comprehensive so that we don't leave any stone unturned. So, Cole, please don't be mean-spirited or disrespectful. I am not trying to straw man anything. I'm trying to address all of the repeated concerns that I'm hearing. I am not trying to straw man. So back to you, Jeff. Are you making lots of extra money off of COVID yourself personally?
No. Nationally, I think the average ER physician's salary has been cut by 20%. Lots of people have lost their jobs.
Okay. Dwayne, how about you? Are you making lots of extra money off of COVID?
No, I'm not. I think, one thing that might be helpful to just a thought I had is that it's a fair point to ask about incentives of people doing science.
Absolutely.
And so I think I would just consider for those folks that are interested in this kind of question, yes, you should look into that and let the light shine where it is. And I would ask that you also apply the same kind of skepticism to the other kinds of information that you might be hearing, because as I apply those same kinds of skepticism that underlying this question, I can see problems in some of the misinformation that I read.
So if there are individuals or media outlets, for media outlets and individuals that are taking one position or another, ask the question of yourself whether they may have financial incentives to speak out publicly for or against any certain side of the issue. Is that what you're saying, Dwayne?
Yeah, and even a bigger issue than that, does it benefit their pre-committed
reputation,
their pre-committed decisions or pre-committed sort of value system that they have? Are they giving room for being wrong? And I think that is a fundamental aspect of how scientists want to operate, is we want to maximize objectivity.
Okay. Thank you, Dwayne. The next kind of category, so the next sort of cousin of this question is hospitals. Hospitals want to make a ton of money, and so they're overblowing this COVID thing. They're diagnosing people with COVID who just have regular colds and flus, and they're actually admitting people to ICUs who really aren't that sick, and even intubating people who really don't have COVID or really aren't that sick, because it's just a way to keep the money, the lining their pockets with lots of money. So Jeff and Stephen, you guys are in the ER. You would be the ones that would be admitting people. I know that for those who have taken the Hippocratic Oath, this is an offensive and an insulting allegation, but I hear it all the time. Hospitals just want to make a lot of money, and so you're trumping up. And you guys would be the ones doing it because you would be on the front lines admitting the people. So Jeffrey, is your hospital pressuring you to trump up COVID diagnoses and admissions to ICU so that they can line their pockets? And then I think, I've already talked about one pulmonary doctor who talked to me about true financial incentives in hospitals and about elective procedures. But Jeff, why don't you just directly address this allegation, and then Stephen, from a totally different hospital, I want you to do the same thing.
Again, like Dwayne said, these are the right questions to ask. But and I see things from my ER world, so I make the decision along with an admitting physician where the patient goes and whether or not they need to come into the hospital. I alone make the decision on intubating a patient. The hospital, no one else is involved in that. So I can unequivocally say, no, there's no pressure to intubate someone. In fact, the pressure is against that. We try to do everything but. As far as admitting to the ICU, the hospital administration is not involved in that decision at all. It's me and the ICU doctor. We have a discussion back and forth. And I've never felt pressure either way. As far as assigning COVID diagnoses for financial profit, I just put what I see. I don't get any kickback for putting COVID diagnosis. I don't know what happens down the line, but who knows? I just put down diagnoses that I see and I feel are responsible, and can back that up, obviously, with good evidence. I'm not going to assign a COVID infection to a car accident. I mean, that's silly. So I can just say what I do. I can't see how that would ever come into play.
Okay. And you know, we still get, you know, there's just this idea of trust. Oak Lancy says, I'm concerned that medical doctors are no longer independent enough to give any unpopular opinions. They fear losing their jobs. So again, Steve, same thing. Are you diagnosing people with COVID, intubating people, admitting people to the ICU out of some type of financial pressure or fear of losing your job, Steve?
Absolutely not. And that's one of the most frustrating rumors to try to debunk. One of the hardest parts of our job is actually to get people admitted to the hospital. That there's huge financial incentives for the hospital to treat patients as outpatients, especially these medical patients that don't bring in, you know, procedures and interventions and stuff. And there have been a lot of COVID patients. I think one of the things that one of the changes in treatment that we've seen over the last few months is we're sending patients home with oxygen now that we used to admit to the hospital. That sometimes if they meet other criteria, we're able to place them on oxygen and send them home and have them use oxygen at home instead of staying in the hospital on oxygen. So all the pressures have been to try to get people treated at home and to keep them at home and to monitor them at home. We send them home with pulse oximeters so they can monitor their oxygen at home, and then they can call nurses and call the hospital back if their oxygen levels diminish. So we've tried to put in place as many things as possible to allow people to stay home, to be treated safely at home rather than keep them in the hospital. So being on the front lines, we see the opposite. We see a real push to send people home versus keep them in the hospital.
Yeah. And I again interviewed last night a Dr. Robert Mildenhall who he's a pulmonary care physician in Nashville. And I asked him this specific question. I'll probably play the interview later. What he said is, if hospitals want to make money, tell me if this is right, they do elective procedures because those are the most profitable procedures. During COVID, elective procedures get diminished and or shut down. And so hospitals are actually making far less money during COVID than they were when COVID wasn't around. So quick yes or no, Stephen and Jeff, is that your understanding as well, based on your understanding of your hospital?
That's my understanding, but I couldn't tell you what the hospital financials are.
Okay.
But typically I think elective procedures are what brings in the vast majority of revenue for hospital systems.
Okay. Jeffrey, you're saying yes
Same,
too.
yeah.
Dwayne, what do you want to say to this idea of hospitals trumping this up to make more money?
Yeah, I don't see evidence of that.
Okay. All right. Well, that's pretty powerful. Okay. So the next category, which is a huge one, is around what people call big pharma, pharmaceutical companies. And I think the logic goes something like this, that these Moderna, Pfizer, Johnson & Johnson, they stand to make a boatload of money because if vaccines are promoted all throughout the world, if they're made mandatory, then pharmaceutical companies are just raking in the dough. And when we look at kind of what happened with opiates, we know that with the pharmaceutical companies can sometimes do a lot of damage with a kind of a profit or monetary incentive. So Dwayne, how would first of all, are you bought off or in any way incentivized by pharmaceutical companies to give the answer you're about to give? And then since you said, major players in the pharmaceutical industry, what would be your honest and best response to conspiracy theories around pharmaceutical companies being unduly profit motivized around the vaccine?
So it's a great question. So first of all, I don't have any interest in any of the companies. I don't have any interest in Moderna, Pfizer, Johnson & Johnson, any of the vaccine companies. I'm interested in vaccine science. I'm driven to do this based on my own curiosity and my own desire to do science. So regarding the question about financial incentives, it is important to have checks, balances, controls, and to watch carefully to sort of make sure that studies and data and recommendations are conflict free. So my first answer is I'm not really an expert in this area. So I'm not really sure, but I can just say what I've observed in interacting with some of these companies. There is an incentive to have a good product. And my sense is that any financial gain or value that they might, get from this is due to a good product that can be proven objectively. And they have to go to the FDA to get approval, and the FDA is not affiliated with any of these companies. They don't have any interest in any given company. Their interest is in the safety and health of everyone. So, in my view, the systems in place are set up to help control for that. Humans are humans, and we have to be skeptical, and we have to watch, and then in the end build a system that we can trust. And I think that the systems in place have those checks and balances.
I mean, some people are going to say, well, the FDA doesn't have perfectly altruistic motives or a perfect track record. And again, we all know that pharmaceutical companies can sometimes act in problematic ways. But I think in every other domain, you go to the doctor, you get a prescription, and in so many instances, you get the medication, and oftentimes you get better. Like, that's the system that's been operating for a long time. And you're saying, Dwayne, that your perception of the pharmaceutical companies as it relates to the COVID vaccine is it's operating under that same standard, where pharmaceutical companies are in general trying their best to provide healthy and safe treatments, that the FDA is doing its best to do its job. And what we're seeing here is the commercial industry with pharmaceutical industry and the FDA and the government all working together to do their level best to provide a safe and healthy treatment to the population. Is that your assessment, Dwayne?
That is correct. And I'll just add just briefly on the end of that. I've been in calls with people that are representing different entities of these pharmaceutical entities. And I've been really impressed of how open they are with their data, with their insights, and their encouragement of finding a solution for a problem. So I'm not seeing, at least at my level, I'm not seeing this sort of concern play out. I'm seeing a collaborative effort to get many products on the out there to people, and an incentive to make a good product that's safe and effective, because in the end, that's best for everyone.
Jeff, your response to concerns about pharmaceutical companies. Unmute yourself. Sorry. Unmute yourself, Jeff.
Again, I think it's a valid question and something you should look into, just like Dwayne said. There are ways to look up your doctor and see what kind of payments they've received from pharma. It's a quick Google search. In the ER, we never see pharmaceutical reps. They don't talk to us at all, because we put people generally on generic medications and for short terms. So I can personally say I have zero influence. They influence my thinking not at all, because I have zero interaction with them. However, like Dwayne said, I feel like this is not really the time to criticize Pfizer and Moderna, because they have literally saved our world from a devastating pandemic this time. This is them doing their job right. They have their problems. I'm no fan, I promise you. But this is one where I feel really thankful that we have pharmaceutical companies that were able to get this out.
Yeah, Stephen, I want to hear your point of view, and then I want to hear your points of view of what would have happened if no vaccine had ever been developed. Just each of you kind of going around. But Stephen, your perspective on pharmaceutical companies. And
so similar to these guys, I've never received a payment from a pharmaceutical company. Never in any of my years, and they don't come. We don't have lunches with pharmaceutical companies. They don't take us on trips. They ignore us in the ER because we put patients on the cheapest medications that we can, because oftentimes there's huge financial needs for patients that come into the ER. And so that's always a consideration. So I have zero financial interest in any of these pharmaceutical companies. And in many instances, I have problems with the way that big pharma functions in our society, and especially in the US. However, I've also worked outside of the US, and most of the innovation and the new medications come through this system that we have established here. So for all its flaws, like Jeff said, I think that that this is an example of these pharmaceutical companies doing exactly what they're supposed to be doing and providing a huge benefit to mankind. That I think that the death totals, and not even just death, but the morbidity, the long-term morbidity from all these COVID patients would be so much higher without effective vaccination. So in this instance, I think that they're doing exactly what we would hope they would do.
So there's been hundreds of thousands of deaths with the vaccine. If you were even to venture a guess of deaths in the US without the vaccine, anybody want to venture a guess?
The numbers tell us 3 to 4 million.
Would have been 3 to 4 million.
Oh, no, sorry. 3 to 400. Let's see. 350 million. I don't know.
Possibly millions.
Yeah.
Possibly millions.
Getting close, yeah.
Yeah.
Dwayne, do you agree with that? Without pharmaceutical intervention in the vaccine, millions of deaths in the United States?
Certainly. So I would need to consult some, my epidemiology friends to really consider all the potential things to consider making this type of calculation. But my rough guesstimation is that it has prevented millions of infections and possibly hundreds of thousands of deaths by this point at least. And who knows in the future.
Yeah. I think that's a really valid way to look at it. It is just flip that question. What if we hadn't had the pharmaceutical companies do what they did? There are a lot of people that express concerns about pharmaceutical companies having limited liability for the vaccines that they produce. I don't expect any of you guys to be experts on legal liability and pharmaceutical companies, so I don't even expect any of you to answer that question unless one of you wants to take a quick stab at it.
I don't have much to add.
Okay. All right. We got a couple more questions. There is just this sort of general resistance of, I don't like government telling me what to do. I don't want political party X or political party Y to be getting into my business. People call it the jab. There's just this general anti-government, anti-authority, distrust of government, distrust of authority, or of being told what to do. Anybody want to take just a very quick stab at that? It's more of an emotional response and a philosophical response than one that really values evidence or data. Do you guys want to speak to that at all? Anybody? If it was a loved one saying that to you, Dwayne?
Yeah, I can just mention this one thing. I think it's helpful to separate the questions here. One is whether or not there is, whether or not the vaccine is safe and effective, or whether or not masks work, and what are the benefits and risks of those. And so I think addressing that as a separate issue, as a scientific one, what are the data, what is the evidence, what are the benefits and risks, and to not let the other very important value issue get in the way of understanding the actual state of nature, like the truth of the matter of, the state of nature about the vaccine, about the risks and benefits. If it's important to also have values. Scientists have values. Everyone has certain values, and we may differ and disagree on certain things, and that's great. That's part of being human. And so I think this argument, John, that you're mentioning now is a value argument in terms of what to do, because information about the state of nature doesn't really tell us directly what to do. We can then decide once we understand the risks and benefits, we can decide what to do about that, whether that is to, let's try to just incentivize everyone to get it, to convince everyone to get it, or to put a mandate in, or this or that. And then what are the risks of that? But what sometimes I'm worried about is these valid value positions. I think it's important to not let them get in the way of understanding what the true state of nature is. Does that make sense?
Yeah. Yeah, it does. It does. So Jeff and Steve, if somebody comes into you and says it's my body, no one's going to tell me to get the jab. Freedom, it's invasive. It's my right to choose. Stephen, what do you tell them in a loving way?
Well, I agree. And I'm glad that it's our right to choose. I'm glad that we don't have government mandates to force us to do things, to take things into our own body. But I mean, the government's involved in all aspects of life. There's speed limits, there's laws regarding seatbelts. And I think that there's a role for the government to play to say, hey, population health wise, this is going to keep more of our patients, more of our population safe. So for them to encourage the vaccine, I think is appropriate. I'm glad that we're not having people that are coming door to door and vaccinating us. What I would encourage people to do, though, is to look for reasonable, legitimate evidence. I'm just a single voice, not normally on the internet. I'm a single voice in the hospital. But every professional medical organization out there, whether you look at the American College of Pediatrics, American College of Family Physicians, American College of Emergency Medicine, the American Medical Association, the consensus is unanimous that the vaccine is helpful, but this needs to be a personal decision. I think people need to educate themselves with reliable information, not just listen to a single person and a single voice, but the scientific consensus is really clear that this is an effective treatment. And it's the only way we're going to get back to normal. It's the only way we're going to keep some of our vulnerable population safe. And, you know, I've got a daughter with special needs. And so this kind of hits home to me that we need to do what we can as a community. And I would hope that we as a community would just say, instead of who's forcing me to do what's my personal freedom? What can I do to be a better citizen? How can I be a better neighbor? How can I be a better American? And this is one of those ways that we can all give back by getting us through this as quickly as we can. But definitely do your research. Find the scientific consensus, and I think that it's pretty clear.
Thanks, Stephen. Jeffrey, your response to somebody that says it's my body, my choice.
No, I was actually only going to add what Steve just got at the end there. I think, yes, it's a personal decision. No one's making you do it. You have an opportunity. I think the evidence is clear from a personal basis, but I also think it's worth considering we all belong to society. We all interact with each other, and we've chosen that setup as for a reason. We benefit from being around each other. And I feel like it's worth turning it around a little bit and say, hey, this is something I might be uncomfortable for a day. I might get a little fever. I might be kind of achy, but I'm doing my part to be in the society and keep a healthy atmosphere for people who can't help themselves, people who can't be vaccinated, people who are really vulnerable and don't have the immune system I have. Like, it's a chance to kind of step outside yourself and do something for someone else.
So again, just to summarize what I hear you guys saying is that even if you don't personally want it, there's some people like, if I'm supposed to go, then it's my time to go. What I'm hearing you all say is, if you don't want to get the vaccine for yourself, consider getting it for aging people that will die prematurely. Consider getting it for people who have illnesses or disabilities that are more likely to die because you spread it to them. Get it for mothers who are carrying children. Get it for your neighbors, for your children, for your grandchildren, for friends, and for society at large, so that the virus doesn't keep mutating and incubating, and again developing even more serious mutations that can come back and continue to shut the economy down, shut countries down, and basically retard the progress of the human race. Consider doing it for those reasons if you don't want to do it for yourself. Is that an okay summary of what you guys are saying?
Yeah.
Okay.
Yeah.
We started with this question, but my friend Russell Webster brought it up again. Some people say this is just the agenda of one political party in the United States or another to sort of do politics and to try and win one political, one set of political successes versus another. I know that we're beating a dead horse at this point, and then I've got a final couple wrap-up questions. Anyone want to take a quick common sense punchy stab at the question that this is all a political conspiracy to advance one party or another, one political agenda or another. Stephen.
The virus is apolitical. The virus doesn't care what people's political opinions are. And honestly, in the emergency department, when somebody is struggling and trying to die, I don't care what their political positions are. My sole job is to just try to keep people healthy. And for those that come into the emergency department, to treat them the best that I can. Nobody cares about politics when people are on their deathbed.
Okay, beautiful. Jeff, what would your response be?
I have nothing to say to that. I'm sorry. It's not politics.
Yeah. Okay. Dwayne, anything you want to say about claims that this is all political agenda?
The only thing the thought I have about that is that I think the process of science benefits from a diversity of thought and viewpoints. And, if the goal in the end is to maximize objectivity and find the true state of nature as close as possible, a diversity of thoughts and critiques and criticism and corrections are valuable. So whether that's, value systems, whether that's other kinds of political backgrounds that's driving people's thoughts to point things out that might give them a different viewpoint of how to see an issue. With science, I think that benefits the process because the truth doesn't change in the end. And ways to look at it and try to falsify it and see if it stands up to scrutiny is, I think, what we value.
I love it. Okay, we have a really good question from a vaccine hesitant listener. Cole writes, the average lifespan of an FDA-approved medication is 5 years before being removed from circulation due to being unsafe. I don't know if that's true. That's what Cole's saying. As someone who's vaccine hesitant, how can I be certain this isn't one of those times where we learn about the harms a few years down the road? It seems that as a healthy 20-year-old who already had COVID, it is riskier for me to get the vaccine based solely on what we don't know at this point. Am I wrong? I think that is a valid question or concern. What about what we don't know? So thank you, Cole, for expressing that. Let's start logically, because there's what we don't know about the vaccine, but there's also what we don't know about getting COVID in terms of the 5 to 10 to 20 year risks. Do I have that right? Jeff, let's start with you.
Yes, I think that's the proper framing. I guess the tricky situation, and I wish people would really go back to that framing every time they look at this. What he's asking, though, I think, is he's already been infected with COVID, already has some level of immunity. Is it worth getting the vaccine when we don't know enough about the vaccine? I guess I would have a couple of responses specific to his question. All of the risks of the vaccine come from that spike protein that's being produced by your cells. You've already essentially had a vaccine in the sense that you've had the virus reproducing exponentially in your body with those spike proteins included. So I would, if I were in your shoes, I understand the hesitance. I get it. You're already sort of immune. Why do something on top of that? But I think the data that says that your long-term immunity is even boosted by getting a vaccine on top of that should be compelling. Even in a low-risk person like yourself, it should tell you that I don't want a full-blown COVID infection because that causes all kinds of problems. I've already kind of survived the vaccine without huge problems or any problems potentially. The vaccine, I know, can boost that future immunity. So in that specific case, I still think it's worth getting the vaccine. The risks are minimal. I'm not sure how to speak to that FDA risk of 5 years. I've never seen that statistic. It wouldn't shock me if it were true, but again, we're dealing with it's not drug versus no drug. It's vaccine versus wild infection. That's really your comparison. You can't just take a break from this. So I would, in your case, I would still go get the vaccine. Seeing what I've seen and reading the studies and the data that I've seen, I would definitely do it. If you're my son, I'd say absolutely go do it.
So, Stephen, a 20-year-old who's already had COVID, getting the vaccine, what are your recommendations?
Yeah, my daughter's 20 and she's had COVID, and I have encouraged her to get the vaccine. And I think that he brings up an important point, that there are lots of long-term things that we don't know about. We don't know the long-term effects of having COVID or having repeat infections from COVID, which we're at risk of if we don't get the vaccine. And we don't know the long-term effects of the vaccine. What we do know, though, is that the history of vaccines in medicine over the last 100 years, there's no question that vaccines are the most effective advancement in medicine in the history of the human race. That more so than antibiotics, more so than surgeries, more so than aspirin and ibuprofen and all these other medications, the development of vaccines have been the most effective advancement in medicine in history. And the side effects of these vaccines are very low. We don't see people walking around with terrible side effects from the vaccines that they got as children. And the more years that we have of data in these childhood vaccinations, the safer they are. Of course, we can argue individual cases that there may be rare instances of harm, but by and large, the benefit of vaccine and the safety profile of vaccines is very compelling.
Okay, that's a great topic. Youth and children, Jeff, I know you have some thoughts about this. There are lots of people asking, is it less of a priority for, let's just say, 20-somethings, which is separate from teens? And I know that the vaccine isn't even available for 12-year-olds, for people under 12. But if someone's doing a risk analysis and they're way younger versus middle-aged or older, what is the thought on teens and 20-somethings versus just sort of weighing the risk and saying, I don't need it, it's not worth it? Dwayne, do you want to start with that?
Yeah, it's a great question. And as far as I understand, it's a question that's still being weighed. It's still being looked at. I don't, there are pros and cons to doing it for kids. I think, studies are ongoing right now, and I think it's just an evolving area. We need to figure out what the evidence is and what the arguments are. So
your professional opinion about a teenager comes in and says, should I get the virus? Should I get the vaccine? What would be your...
Oh, for a teenager, a 13 and above, it's recommended. And I have a 13-year-old and she got the vaccine.
Okay. Okay. Jeff, I know you have some thoughts about this.
It's a gray zone. It's a great question. My thoughts have kind of evolved in this. I was initially saying, no, kids should not be getting the vaccine. They're just not the risk factor.
When you say kids, you mean young teens?
Yeah.
Right?
Let me clarify. Yeah. Initially, I thought kind of under 18 and really even people in their 20s. As I saw more people in their 20s get sick, really sick, and we're seeing that more and more with the Delta variant. It's affecting people in their 20s more than the others have. That's changed my thinking. I think 12 to 19, I now fully support vaccination on. No, we're not seeing them get sick to the same extent, but they are spreading it at very high rates. And as opposed to the kids under 12, for some reason, they are just not huge vectors of disease. As far as I know, as far as we're seeing, they're just not huge vectors. So the benefits are getting really low. I still haven't seen a sick kid under 12 over a year and a half. Personally, that's anecdotal. I've read reports. I'm not a pediatrician. If you had a peds ER person on here, they may be able to change that. So take that anecdotal stuff for what it's worth. But under 12, I still think it makes sense to wait, and we'll see what the data shows. It's not going to be approved for kids under 12 unless there's a really compelling benefit. But teenagers, I think you have that vector benefit. They really are spreading it at high rates, even if they aren't getting sick themselves. So there's a very big benefit there. But the other thing to consider, just physiologically, this is theoretical. It would be really hard to study this. But remember, the people getting sick from COVID, they're getting sick because they're reacting to that spike protein and the uncontrolled reproduction of the virus. I would propose that people that aren't going to get sick from COVID are not going to have the same level of reaction to the vaccine either. So people who are low risk COVID are also really low risk vaccine. Because it's essentially the same thing. The virus is the vaccine plus a whole lot of other junk. That's what it really is. If you choose not to vaccinate, you're really choosing to vaccinate. You're choosing all the harms of the vaccine plus a whole lot of other things that come with it.
Excellent. Steve, you've already talked about what you would recommend to your own 20-year-old. Jeff, I think your point about teens getting it just to not become super spreaders is a really valid point. Stephen, anything you want to add about teens or 20-somethings that beyond what you said?
Well, we are seeing, and I can't give you the specific numbers, but on an email from IHC that I got just 2 days ago, that they are seeing an increase in pediatric hospitalizations due to COVID. And we don't know what the winter's going to hold. You know, when we have RSV and influenza and all the other viruses, and if we're not wearing masks, and then you add COVID into the mix, potentially things could get really ugly for kids and teens as well. So I'm an advocate. I think that, like Jeff said, I think that the potential side effects of the vaccine in young kids is going to be low, because we're not seeing a ton of them that have gotten super sick, but we are seeing an increased number of hospitalizations in pediatric patients over the last couple of weeks.
Excellent. Okay. Couple other, one really important question that we haven't really responded to yet, and I think it's really important. There are people that shouldn't get the vaccine. Is that true? And if so, who should not get the vaccine? Or am I wrong?
This is Dwayne, I think.
Yeah, I think if you have had an anaphylactic, event or a severe allergic reaction, that would be something you would talk to your physician about, your risk, and to suss that out. Okay,
so talk to your physician. But are there just categories of people that it's like, yeah, it could be very dangerous for you? I hear the term immunization compromised, immunity compromised. Like, are there categories of people that generally, under the supervision of a physician, need to at least ask questions and have pause before they just jump in and take it?
I got that question a lot. I see immunodeficient folks, and I recommend for them to get the vaccine, and they're getting it. Some folks that are immunodeficient may not respond as well because they're immunodeficient. Their immune system doesn't work as well, so sometimes they don't respond as well as others who are not immunodeficient. But with the vaccine, with this kind of a safety profile, to me, it makes sense to recommend the vaccine to folks, even if they're immunodeficient. In fact, they're recommending boosters for those folks because, a booster can help induce a stronger response to help protect against the virus in these folks.
All right. Jeff, anything to add about who should not get the vaccine?
I mean, I think Dwayne is the expert on this. This is his field, but this isn't like other vaccines, some of which will contain some live virus. That's not at all the case. So immunocompromised patients are still safe to get this. They just might not mount the same immune response. I mean, he's the expert.
Okay, Steve, anything more?
No, same.
Okay. A couple just super quick ones, and then we should wrap this up. Several people asked if the virus was engineered. My quick answer is it doesn't matter. We have it now, and we got to deal with it. Anyone else want to add anything beyond that?
Yeah, I think there's some conflicting information. And that's not for any of us to decide. Who knows? But we're dealing with it now. So wherever it came from, I think that the better question is how do we respond to it now? What's the best thing that we can do as individuals and as a community to get through this now?
Okay. A quick answer about the effectiveness of the vaccine on the Delta variant. So did the Delta, I know you've already addressed this, but just to address it punchy and quick, is the vaccine effective against the Delta variant? Jeff?
Remember what we cared about at the beginning of this? The most was hospitalizations and deaths. So 100% it's effective against that. It's less effective against infections, still very effective, really off the charts effective compared to lots of medical treatments lots of you have already taken. But 70% is a great number, medically speaking. But yeah, it's still doing exactly what we wanted it to do.
Stephen?
Agree. I think that the data strongly supports it. It may not be quite as effective, but it's still going to decrease the severity of illness, hospitalization, ICU stays, and death.
Dwayne?
Yeah, data support that.
Okay. If somebody is saying, okay, you convince me, I'll get the vaccine, but I want to get the best one. Are there some vaccines that are better than others? Should they be, making a call about which one they get? Jeff, I saw your eyes go big there. Is that because that's a tough question? You're muted again, Jeff.
Just get something, but Dwayne can probably speak to that specifically, or Steve, I don't know.
Okay, Dwayne.
I would say any vaccine that's currently available is better than no vaccine. So if you have an opportunity to get the vaccine, I would get it. The mRNA vaccines tend to make higher antibody levels, and they, in clinical trials, slightly higher. But, so if you have the choice, those are your options.
Which ones are mRNA?
That's Pfizer and Moderna.
Okay. Steve, anything you want to add?
Yeah, I agree. I think whatever you have access to, I think that the data supports that Pfizer and Moderna, that their efficacy is a little higher.
And Johnson & Johnson.
And the vaccine's free. Anybody can get it. You can go to Walgreens now. They've made it so easy. So yeah, I would get whatever you can.
Okay. Jeff, anything to add to that? Okay. You can stay unmuted, Jeff. We're about to finish. Someone asked, do vaccinated people still need to wear masks? What's the CDC guidelines for that? Anybody know, Dwayne?
I actually don't know. I'd have to look those up to see. I know that, some local areas are making some suggestions and sometimes, requirements in certain areas of the workplace. Masks do help prevent transmission. And we know that even the vaccine is effective. It's not 100% effective. Some people can still get the virus and actually spread it with the vaccine. So masks will help reduce the risk even if you're vaccinated. How to deal with that in terms of what you do is kind of up to policymakers.
Steve and Jeff, anything to add there?
Masks work. I've been vaccinated. I've also had COVID, and I wear a mask at work all day, every day. So if you're in doubt, if you have questions or concerns, if you're in a big public area, then there's no harm in wearing masks, and there's potential benefit.
Okay. What about a booster? Oh, Jeff, did you want to say something about masks?
I think any of us would be hesitant to make general recommendations to people because different situations vary so much. I think we're moving towards masks in shared public indoor spaces, given even vaccinated people. As much as I hate that idea, I think we're moving towards that. But like the more broad point is, I feel really uncomfortable telling someone else's in their community whether or not they should wear masks. I think I've been swimming in this all of my life for the last 18 months, like 24/7. And I feel uncomfortable taking a strong position on that. Please just listen to the experts. Your public health officials, they have access to information you don't have. They have access to information I don't have regarding your local situation. So I would just, again, encourage you, listen to your public health officials and just follow directives. If everyone would do that, we would be done with this.
Okay. Really quickly, people are asking about the booster. Is a booster coming? Is it useful? Is it necessary? What does the science, the evidence say about a booster? Dwayne?
Several months ago, Pfizer came up with this because of their data tracking antibody levels, seeing that they dip after several months. And we know the effectiveness might wane over time. The vaccines are still, safe and effective, but, the point at which we may want to get a booster, ongoing discussion. It may be needed to keep the immune system strong against the virus.
But we don't quite know yet.
As far as I understand, we don't quite know yet. It is recommended for the immunodeficient now. And if the antibody levels kind of sagging down that we see, if that's an indicator that the effectiveness will also sag, then a booster might be in the future in a few months.
So if you're immunodeficient, a booster is recommended. Otherwise, data is inconclusive, correct?
As far as I know, yeah.
Okay. Jeff and Steve, anything to add to that? Okay. All right. I'm going to make one. This is kind of a weird thing to do. But I'm going to throw one more question at you guys. And I'll just, there's been several comments. Here's one. Good thing you got the pro-vaccine guys on. Otherwise, your show would be purged. Too bad the truth is censored. There's a lot of other people who wrote that this is an extremely biased panel. And, you know, the argument, and I even had some people close to me make this argument, it's if you really want to be credible, bring on people who are against the vaccine. Bring on doctors that say the vaccine is dangerous, or bring on people who claim to have been harmed by the vaccine injured, and that's the only way to have a truly unbiased panel. I have my own reasons for why I didn't take that approach. I don't think I assembled a biased panel. I think I assembled a panel of people who have real world experience, whose honesty and integrity and credibility I trust, who are familiar with the science, who are familiar with the evidence, and who have boots on the ground treating this stuff every day. So for me, I'm going with the science and the evidence and with as much credibility as I can. That's how I assembled this panel. If each of you want to just respond to the claim that for this to have really been a good panel, it should be unbiased, which means it brings on people who talk about alternative treatments, who talk about vaccine injury, or who claim to have been injured by the vaccine, and only that would have been a good panel. I want each of you to have a stab at why maybe you wouldn't have even been willing to appear on the panel if that had been my approach. So Jeff Gardner, I'm going to ask you to first respond, then Stephen, then Dwayne. What would your response to that be, Jeff? Just for people that want to undermine just this panel overall. And unmute yourself, Jeff. Sorry, unmute yourself. And then I know it's weird to defend your own credibility, to be asked to defend your own credibility, but just give your best logic, reasoned response to those sets of arguments I just levied at you.
I think Dwayne and Steve are both nicer than I am, so I'm glad that they're going to tone my words down here. I have come at this from a skeptical point of view from the beginning. I figured this was going to be another flu. I said that. I've said that publicly. I thought this was just going to be another flu. I didn't want to do economic shutdowns. I came very reluctantly at every point, kicking and screaming. I am at the point where I think the science is undeniable. I think if you were going to bring someone on here at this point who really was against, who felt the vaccine didn't work, or felt that it wasn't effective, or felt like COVID was overblown, or any of a variety of positions I've seen, at this point, they literally are not looking at the evidence honestly. It's just overwhelming. There's not two valid sides to this. Ken Ham they had that debate over evolution a couple of years ago, where it was silly because it gave credibility to a side that just doesn't have credibility, and it gives air to arguments that just aren't valid anymore. You might as well have someone come on and say, we just need to sprinkle pixie dust. It's a valid position because someone holds it, or is it a valid position because they have some scientific background behind it now? I'm telling you, there are people that are talking and they're speaking dishonestly, both about their experience and their motivations. And that bothers me a lot. And at this point, if you're saying those kinds of things, I know some of this stuff personally. I know where they're coming from, and they are not being honest with you. And I'm not willing to entertain those kind of arguments.
There's a lot of people bringing up ivermectin again. I just want you guys to go back and listen. We've already addressed all the alleged treatments, and there's nothing known that's faced the scrutiny of a randomized clinical trial that is found to be credible or effective in terms of a treatment, including, just including everything, because Jeffrey and Stephen and Dwayne would be prescribing it if it existed. So that's the answer to anyone who's trying to come up with, what about this? What about that? What about some other treatment? There is no known treatment other than the vaccine that has survived a randomized clinical trial that can be prescribed by doctors in the know. And that's for just all the people that are throwing that up again. We've already addressed that. Stephen,
And we've been looking at that for a year and a half. I just really, ivermectin is not a new thing. And none of these others, there are people that really are excited about having a voice in the discussion. And so they'll take advantage that the public has not been swimming in this for 18 months. So they think this is a new idea. If you haven't been paying attention for 18 months, it might seem like a new idea. It's not. And it really frustrates me that there's these dishonest voices out there. I'm not criticizing the questioner at all. I think they're being taken advantage of by people with agendas.
Yeah, Rosie makes the point. Are there through a question, are there credible anti-vaccine doctors? That's Rosie's question. Steve, what's your answer to the claim that we should have had, quote, an unbiased panel bringing on people that testify about vaccine injury or medical doctors that are opposed to the vaccine? What's your response to that claim?
So my response is I work in a couple of emergency departments here on the Wasatch Front. I also work in Alaska. I've worked around the country and out of the country as well. And I don't know a single medical doctor that is actively taking care of patients that is anti-vaccine. Not a single one in my hospital, and any of the 3 hospitals that I'm working at now. Every physician that I work with has been vaccinated. We have family members that are vaccine hesitant. Some of my colleagues have family members that are vaccine hesitant, but not a single physician that I work with is vaccine hesitant. And they've all been vaccinated, everyone that I know about. And then again, I'm just a single voice. And Jeff and Dwayne are single voices, and this panel is composed of, what we're composed of. But if you really want to get the scientific consensus, you have to look at the sources. And random Facebook groups are not credible sources. But if you look at the CDC, the WHO, and like I mentioned earlier, any professional medical organization is going to be pro-vaccine, is going to recommend the vaccine for the vast majority of people. And I think that's where the truth lies, is the real scientific consensus. You're going to find outliers anywhere in any subject, in any discussion. But the scientific consensus is overwhelming that the vaccine is safe and effective and that we should all be getting it.
Yeah, I love it. And of course, again, MJ writes, I personally know medical professionals that are against the vaccine. That's fine. I think the question for people that we're trying to reach, the question is, what is the preponderance, the overwhelming consensus in the scientific and medical community? What is that? It's not, what does some person that someone knows on the internet believe? It's what is the overwhelming consensus of the scientific community, of the medical community, of medical health professionals, of the public health professionals, of science valuing people worldwide. What is the overwhelming consensus? That's what I care about, and that's what's gonna govern me. Dwayne, anything you want to answer to the allegations of a biased panel? Allegations of a biased panel.
I don't know how to respond to that. I guess to be unbiased is the goal. So we all have our biases, and so anyone's criticism is I'm happy to listen to and to receive that feedback. I think an important thing to realize is, in my view, we're all on the same team. There's a virus. There's plenty of evidence to understand what this virus can do and the harm that it has on our loved ones. And I think we are trying to find solutions to this. And the vaccine as a preventative measure is one solution. And I get it. It's hard to see at a personal level, the impact of the vaccine if you get a vaccine. It's not like, a kind of a therapy that you immediately feel better about it or something. It's a therapy you get that prevents something that you may never see. Or if you do get COVID after you get vaccinated, you never see how sick you could have gotten that we suspect that would happen because of the data of all the evidence around that point to that. as an outcome. So I get it. It's hard to see, and it does require to step back and to be thoughtful about it and to consider the evidence. So for those that are thinking that this is biased or that there are other kinds of viewpoints, if there are valid viewpoints out there, I want to learn them. I am a student. I consider myself a learner. I want to be open to change my mind if there is evidence out there to suggest that that should happen. So far, the overwhelming the evidence out there is overwhelmingly in favor of a vaccine and the health benefits of that, plus mask wearing and stuff like that. So that's why I stand where I am, and I think that those that are skeptical of that, I hope that folks will be open as well to look at the evidence across the board and to learn together.
I love it. Well, I'll share one of my favorite comments of the whole time. It's from Adam Hewish streaming. He says, this is the best thing I've seen with COVID. Thank you. Several other people wrote that as well, that in their opinion, this has been the best conversation about COVID that they've seen on the internet or on media, full stop. And I just want to say, I am just so incredibly grateful for your hearts, for your brains, for your courage, Jeff, Steve, and Dwayne, and for your willingness to speak up publicly. I knew from the beginning we weren't going to please everybody. I knew from the beginning there were plenty of people whose minds were made up, who we weren't going to move the needle. Though this whole episode was targeted at people who are still open-minded, who value evidence, who value what's going on around us, and who are open to the evidence, the data, and the evidence, both scientific evidence and the evidence of what's going on in hospitals in Utah, in Idaho, in Nevada, in Massachusetts, and around the globe. If people don't value that, maybe there's not so much more we can do. What I want to do now is aside from thank you guys, is just give each of you one final chance to either give closing comments or make whatever statement you want to close as a wrap up. So Dwayne, thank you for joining us. Dwayne, is there any final comment you want to make to those who are listening?
One thought I had just to wrap this up, my thoughts, thinking about reasons to get a vaccine. There's enough evidence out there that we're convinced that there's benefit. There are lives to be saved. And so, rarely is there a time in history where any activity that we can do as a group can actually save lives and increase their dwell time on this planet. In intensive care settings and in settings where we want to give people an extra day or two, it's so valuable to have time on this planet. There's a lot of stuff to do, and it's hard to translate these numbers that we're hearing. Hundreds of thousands of deaths, people dead, people's brothers, sisters, fathers, mothers, grandparents that are no longer around because they died of COVID-19. It's hard to kind of feel that if you haven't experienced it yourself. There is a prevention for that. The vaccine can prevent people from dying. And so you getting a vaccine helps with that endeavor because it reduces the probability of variants to emerge, to escape the vaccine. It reduces the community transmission and overall risk of anyone getting the vaccine if a community gets a vaccine at a high level. So as a community, it's an act of service. And if you're at 20 years old and aren't going to get sick because you're in that group, it's an act of service. It's a Matthew 25ian first two commandments by one act.
I love it. I'm sharing visually all the overwhelmingly positive comments coming in from we've had a large viewing audience. Over a 3-hour presentation, we've sustained between 600 and 700 simultaneous viewers at any given point. And that's a great show up. So I'm so glad you guys, we've reached a lot of people. And of course, when this gets posted on YouTube and on Facebook asynchronously and on the podcast. We're going to reach tens of thousands of people, but overwhelmingly the people who have been joining us are super grateful. So I love that heartfelt summary. Dwayne, I'm so grateful you were willing to join us. I'm going to share visually all the other thank yous that are emerging. Stephen, let's have you go next. Your wrap up thoughts and feelings.
Yeah.
Or summary statement.
I really agree with what Dwayne said and echo what Jeff has said throughout this time as well. I appreciate you guys and the work that you're doing, and I just would encourage people that this is something that can change lives. It can better our communities. It can get us back to normal sooner rather than later, and that's what we all want. I'm a dad. I'm somebody that likes to go to live shows and to go out. And this is the one thing that's going to get us back. I think that we're all sick of this. I'm tired. I'm tired of the pandemic, and whatever we can do to get us back to normal. And the thing that is most effective is going to be get the majority of the population vaccinated. That's the one way that we're going to get through this.
I love it. And Steve, I love you and your family, and I'm so grateful you're willing. I'm so grateful to have you on Mormon Stories podcast, Steve. It's great it's either good or bad that this is the thing that brings you on, but I'll take it. How's that?
Thanks, John.
All right. Love to you and Mindy and the whole family. All right, Jeff, you were the one that stepped up and said you would kind of coordinate and lead this. So I wanted to give you the final word, Jeff.
And I don't do that being the most qualified at all. I think there are a lot of very smart people who could have been on here and probably made points in a better way. But this feels more like a passion than about anything I've done in medicine. We all go into medicine with the idea of helping people. We want to relieve suffering. We want to care and connect with other people. And we give a lot of therapies in medicine, and we act off imperfect evidence a lot because we have to. We go for 10% survival benefits. We go for, if we get one of the numbers we look at a lot is number needed to treat. And if you need to treat 10 people to save a life with the therapy, we think that's awesome. There's a lot of benefits that we use pretty routinely in medicine that are a lot less effective than what this, I can't really call anything other than a miracle. I never thought there was a chance we would have a vaccine in the first year of the pandemic. I didn't think that was even in the cards in any way. And to see one that is effective like this and can prevent so much suffering and so much hardship and so much death, it's a no-brainer to me. So it's been challenging the last 6 months, not watching everyone just crowding the pharmacies to get this. I think if they saw the data in an unbiased way, they would. But unfortunately, there's a lot of voices out there that are either willfully or ignorantly misrepresenting things. So it feels like a passion to get this out and get people on board with something that can really help them and others. I love how Dwayne and Steve both framed this. We're humans. We just want to help people. And this is your chance to take Matthew 25:40, which, whatever your view on Mormonism, that is, it's hard to argue with that one. As far as a personal ethic, this is your chance to do something for yourself and really for your community, and with minimal cost or burden to yourself. Go get vaccinated.
And I particularly love it when kind of my maybe my slightly more secular leaning friends, or even not super religious friends, are who are science loving and science valuing friends who are speaking of the vaccine in terms of it being a miracle, being miraculous. That really says something to me. You guys are kind of using almost religious language to speak about something very scientific.
I have like goosebumps. I don't get that in medicine very much. I'm jaded.
Well, the comments are overwhelming. And Dwayne, there's a Daniel who shares your last name, Dwayne. Is that somebody you know?
That might be my older brother. Hi, Danny.
All right. Shout out to Danny. All right, everyone. This has been so great. This panel exceeded my expectations. Thanks to everyone who shared their comments. There's a lot more we can discuss. There's a whole angle that we could discuss about President Nelson. Did he do the right thing? Was it too little, too late? LDS Church's response, members' response, people losing their faith over this. I left all that out on purpose because what I care about right now is that COVID spreads the least possible amount, and that the most people stay well. And for what I think, what that means based on this panel and my understanding of the evidence is, which is just that as many people get vaccinated as possible. I hope that we've made a compelling case. I hope we've made a respectful case. I hope that people feel like we weren't disrespectful or straw manning opponents to the vaccine. I hope people understand why we made the editorial choices we did in assembling this panel. And then most importantly, if you feel like this panel could be helpful to not everyone, but to people who value evidence, who are just hesitant or unconvinced, but need some support from doctors on the ground, doctors in ICUs, doctors who are watching people die, and doctors who care about science and value evidence, and who are just good humans trying to make the world a better place. Please share this episode with whoever you think it might be useful for. And if you don't think this is going to be convincing, find your own way to share convincing, relevant information. And I'll just say, don't do it by being demeaning or disrespectful or insulting, because or even combative, because what that creates is called the backfire effect, which actually makes people hold on to their beliefs and views even more strongly. Do it with love, do it with compassion. What I do want to make a final call for, I want to potentially do an episode of vaccine hesitant or vaccine resistant people who then got COVID or whose loved ones got COVID, and they're willing to sort of share their testimony about how much they regret not getting the vaccine, and how awful it was to get COVID, and how getting COVID and or seeing their loved ones get COVID and or die has changed their views on the vaccine. If any of you or anyone you know is willing to tell that story, I want to bring you on, because I'm told that might be the most effective way to change the hearts and minds that are willing to be changed. If you fit in that category, please email me at mormonstories@gmail.com, and I want to string together a Mormon Stories podcast episode for those stories, because hopefully that will move the needle. I also want to say it's obvious that I have a cold. My dear friend Gerardo, I scheduled a COVID test last night at like 10 or 11. It's not until 2 days. My dear friend Gerardo got on a COVID testing site and literally scheduled a COVID test for me for like 1:30 this afternoon. And it's a rapid COVID test. So I will be COVID tested, and that will inform some of my decisions later on in the day, which I'm not going to talk about here on the podcast. Why are you smiling, Jeffrey and Stephen? So without any further ado, thanks everyone for joining us today. Thank you, Dwayne. Thank you, Jeffrey. Thank you, Stephen. Thanks for all the commenters. Thanks, Gerardo. Thanks, Kara. Thanks to everyone who helped me prepare for this. Thanks to the Open Stories Foundation that made this episode possible. Thanks to donors. I do want to make a final pitch. We lost donors just by announcing that we were going to do this episode. I had several donors say, John, I'm canceling my donations. You went and got political. You're going to talk about the vaccine. I'm canceling my donations to Mormon Stories podcast. That's people's choice. And I just want to know I just want you to know, if you value Mormon Stories podcast, if you value this episode, and if you don't want to see Mormon Stories go away, because we tried to give an evidence-based panel discussion about a public health issue. If you don't want to see Mormon Stories podcast, and because we chose to do what we thought was right, even if you disagree with our conclusions, if you value Mormon Stories podcast and don't want to see it discontinue, please go to mormonstories.org, click on the donate button, become a monthly donor, because we would love to replace the people that canceled their donations because we covered this topic with people who are grateful that we had this panel and were willing to cover this topic. So please become a donor at mormonstories.org if you're willing. Jeff, Steve, Dwayne, you're awesome. Thanks so much. Email us with your feedback at mormonstories@gmail.com. Share this with everyone. Please continue the comments and the conversations. And please just be responsible. Don't spread misinformation. Don't spread anecdotes. Don't spread unscientific conclusions. Just follow the evidence and follow logic. And let's get, I'm going to say it, let's get vaccinated, everybody. Thanks, Jeff. Thanks, Steve.
John, stay safe, everyone.
Take care. Thanks, listeners. We'll see you guys all again soon. I'm so sick. On another episode of Mormon Stories Podcast. Take care, everybody.